Good afternoon. I'm Dr. Andrea Chisholm, Deputy Director and Chief Development Officer of the Trust, and I'm glad that you're able to join us today for our first webinar of the year and the eighth part in our Business of Practice webinar series titled Beyond Fear and Hype, Artificial Intelligence, Ethics, and Clinical Judgment. Presenting today's webinar are Drs. Liesl Bryant and Donna Shapires. Dr. Bryant is a Trust Risk Management Consultant and a frequent presenter of our risk management roundtables. She's also one of 8 advocates in the Trust Advocate 800 program, our complimentary consultation service that provides policyholders with unlimited and confidential risk management advice. If you aren't familiar with this valuable resource, I encourage you to check it out. Most recently, she was appointed to the APA Expert Advisory Panel on Artificial Intelligence, further advancing her work at the intersection of ethics, risk management, and emerging technologies. Dr. Shapires is a professor and chair of the counseling department at Palo Alto University and director of the eClinic at Palo Alto University, a nationally recognized digital health training clinic. Her work focuses on ethical AI integration and digital mental health education with more than 30 years of clinical experience informing her leadership in the field. We hope you find today's presentation informative and worthwhile. Please join me in welcoming Drs. Bryant and Shapires.
Great. Thanks so much, Andrea. It's really wonderful to be here with you all. So welcome. I know Donna and I are really looking forward to this, so we're really glad to have all of you there. We're really, right now we are practicing in a moment of huge transition, right? Very real transition. And artificial intelligence is already shaping the clinical work that we're doing, and the choices that we make now about AI really matter. They matter now, and they're going to matter absolutely critically for the next 5 years, 10 years, and so on. So our task today is to really engage thoughtfully about AI. We're not for AI, we're not against AI. We really want to, or maybe we're both, I see Donna, I was like, yeah, Donna and I've had a lot of conversations about this, right? But what we want to do is strengthen our practice while keeping clinical judgment and responsibility at the center. And so we're going to talk about what that means and ways to make sure that we do that so that we can use AI to improve our systems and our practices, but doing so in a safe way. So in terms of our agenda, here's how we're going to walk through the material. We're going to begin sort of with a broad landscape, what's changing, why it matters. From there, we're going to look at how authority and ethical responsibility can shift in subtle and often invisible ways. We're then going to move into the practical architecture of risk management in an AI-influenced era and care. And we're going to close by clarifying the kind of disciplined, defensible stance that allows us really to steward this transition well and hopefully together, right? So that none of us are in it alone. These are the learning objectives. I'm not going to read through them. You have them in your handouts there. So we're going to dive right into the material. I know there's going to be lots of times where we're going to hopefully have some time to do some polls and some interaction. But so just to start, why does it matter now? Occasionally in our careers or lives, right, the environment in which we practice starts to shift in ways that are really profound. And we're in that moment now, right? You'll see throughout the presentation our earthquake shifting tectonic plates metaphor. And it really is. This is a profound change. And it requires not just caution, but importantly, it requires recalibration and stewardship. And we'll talk more about that later. I also just want to note, if this feels destabilizing, it should. It is destabilizing, right? It's overwhelming. And periods of intense structural change will feel that way. Our goal today is to give you some education and talk us through different pieces to give us all a little bit of grounding. And Donna, I see the poll coming up here. I'm going to let you talk them through this.
Sure. So if you'll just take a moment to respond to our first poll, which is really just what is your current role? We'd like to best understand our audience. And as you're finalizing your responses, Liesl is going to be talking more about where we are on that shifting tectonic plate. And I'll share the results of the poll in just a moment.
Okay, great. Let me move the poll out of my vision. Oops. Actually, I think it's not going to let me. There we go. All right. Inflection points occur when several forces shift simultaneously, right? Capability here with AI, capability has increased dramatically. I read a quote a while back that said that it increases every 3.5 months, it triples in power, which is pretty astounding. Like, that's a pretty fast rate. Access now is nearly universal, or is becoming more so, not fully, but certainly more. Cost is dropping. So it's becoming more integrated into documentation systems, supervision workflows, training environments, etc. And when these curves start to bend together, change is no longer incremental, it's structural, right? So I'm going to pause. Donna, do you want to dive back in?
Just for a moment, because as we're talking about what you're really dealing with today, a lot of that has to do with the role that you approach this work from. Most of us are actively in clinical practice, but we do see a healthy dose of those of you who are also providing supervision and education. And that's a lens that we'll definitely be focusing through as we go further in this webinar.
Yeah, so that's great to know. Where each of you are, and we'll sort of talk. Certainly a lot of this is going to focus on clinical practice, but we'll hit on different pieces as well. So because of these structural shifts, right, AI is no longer just confined in many ways to administrative tasks. It's really entering the domain of clinical judgment, and it's doing this in a lot of different ways. For most of the time that all of us have practiced, right, it's often looked like us sitting with our therapy clients, us taking notes, right? We remember what happened in session, and then after session, we go and write down those notes. We read manualized treatments, those kinds of things. And now we're shifting into AI-generated treatment and case summaries, on-demand literature synthesis, differential suggestions, drafting clinical language. So this is really a transformation in the field that really changes the context in which our judgment forms, right? The conditions under which we think are changing. So we're not just adding a new tool, we're really altering the environment in which we're working and in which our clinical judgment is exercised. That also means then that the standards of care are starting to shift and will shift and should shift over time, right? As we start to see more of this happen, more AI become involved in clinical care. So when enough clinicians start using AI-assisted tools, expectations change. We see that what counts as reasonable diligence, say adequate documentation or informed consent, that evolves. And we're going to talk some about that this afternoon, a little bit later. We also see that new risks are emerging. And with AI, that can be things like automation bias, over-reliance, diffusion of responsibility. So it means that we're entering a period where both action and inaction carry risk. So I really do think, and Don and I have talked a lot about this, we can no longer say, I'm not going to use AI, I don't want to think about it, I'm not going to learn about it.
I don't think we hear that as much either, Liesl. Even just a year ago when I did my first webinar for the Trust, there was more of a, maybe I just won't do this at all. And I think most of us now are like, well, I at least need to know about it.
Oh, interesting. I still hear quite the opposite in a lot. I do. A lot of clinicians are saying, no, I don't use it. I don't want to know about it. I don't think about it.
Maybe it's just this room, because I hope all of you that are here are at least open to knowing about it, because that's why you're here.
Yes. Well, and if not, we hope to change your opinion, because that passive disengagement really isn't going to be sufficient. And we'll talk more about the reasons why, but really it's because it's happening whether we like it or not. It's already occurring and influencing us. Even if you never touch AI, your clients are touching it. The system in which you document may have it, so there's a lot of ways that it's coming in anyhow. So what's absolutely required is a lot of learning and education, which is what we're doing today, and really deliberately positioning ourselves on ethically solid ground. And we're going to talk about what that means, right? In mental health care, as we all know, caution is not optional. It's a professional responsibility. And there's really cautions in both directions. On one hand, there's a risk of premature adoption, right? If we integrate tools before we understand their limitations, that can be a problem. Biases and other downstream effects can actually harm clients and can distort clinical judgment, which is a real problem. So we can't integrate tools if we don't understand them. At the same time, Again, it's already there. AI is embedded in many documentation and systems and EHRs right now. It's there in supervision practices. It's there in some institutional policies. And certainly it's there in the hands of our clients who are using AI chatbots and getting information about their own healthcare. So our risk of professional unpreparedness is also dramatically increasing. So this means that there's a shift in our risk calculus, right? We can neither do one, we can't sort of lean too heavily in one side or the other. As we move through the material today, we're going to be identifying fault lines. The idea here today is that we're not predicting any collapse, so let's not terrify ourselves. There are actually good ways that we can walk through this in safe, ethical ways. But that doesn't mean that we're going to do it haphazardly, right? Caution is required. So we're going to think about that as we move through and locate where that needs to be. So what does all this mean? Well, we're going to start with what it does not mean, and then we'll talk about what it does mean. So it does not mean that everybody should adopt AI immediately. It also does not mean that no one should adopt AI, right? We're going to talk about when we adopt it, when not, when to be cautious, those kinds of things. It does not mean that there's no ethical or risk management reason to limit AI use. There actually are some, and we'll talk about what those are. It also does not mean that human judgment is going to be displaced by AI. I actually don't think that will happen, but we also need to work to make sure that it doesn't, right? So it does mean that our default stance changes, either from permissive disengagement or dismissal to, okay, now we have to engage with this. We need to carefully evaluate what are the pros and cons and risks, and how can I use it in ways that are safe if we're going to use it. AI is no longer a technical sidebar. We're going to talk about ways that this is very, very different than a lot of the tools we've used before. We have to really understand those differences. It also means that just because industries might adopt AI, or someone at your work says, yep, we're using AI, that does not equal ethical legitimacy. And we're going to talk about some of the ways to interrogate that, because we have to be really careful. The world is moving forward, but as we'll see, we have to be a little more thoughtful in the world of mental health care. And there are going to be times where you're going to want to delay and or maybe in some instances decline adoption. And that's of course okay too. Today, really, we're not trying to push AI nor deny AI. We want to find that sweet spot. Now, as I said, AI is already shaping our practice, right? It's embedded in multiple systems. Insurance review processes are using AI, documentation system, decision support. So it's really showing up in lots of places. And many clinicians are interacting with AI-influenced outputs, even if you wouldn't really describe yourself as using AI specifically. So the very first sort of ethical stance we have to do is simply recognize that's the new reality that we're in. We also have to recognize that technology is moving at a much faster rate than our ethics code and legal standards, right? So right now, our professional code and legal standards are responding to AI, not setting the pace. And I actually think that's a problem. But what it does is it creates a lot of ambiguity. And that ambiguity actually increases our responsibility, right? Now, behavioral health, right, in our field, we're not just managing data. We're working with people, right? We're working with trauma and vulnerability and suicidality and identity and trust issues. So when AI enters our space, the impact is not only technical, it's also relational and psychological. And that means that our discernment has to be greater and a little bit more cautious. And then in addition, right, even when the tools are opaque, we remain accountable. So many systems, many AI systems, I should say, are proprietary. They're not fully explainable. We'll talk more about what this means in just a few minutes. But that lack of transparency does not transfer responsibility, right? We can't say, oh, I did it because AI told me to. That isn't going to work, right? So accountability will remain attached to us as the licensed professional. This means that what we're really trying to do is preserve our judgment, accountability, and explainability. And to be clear, in the AI world, explainability is about having the ability to clearly understand and articulate how an AI system reaches a particular output or recommendation, right? If you don't understand that, it can cause issues. Just because there's not clear regulation, again, that does not equal permission. What it does is it increases risk in many ways. And when risk increases, our professional responsibility also increases. So one of the big take homes that you'll sort of hear throughout this is the responsibility remains with us at all times. And we actually, I think, want to lean into that. And there are ways that we can do that. And we'll talk more about that. So what has not changed? Well, thankfully, our core ethical anchors have not changed. This is what we ground ourselves in, right? Beneficence, non-maleficence, fidelity, justice, respect for dignity. None of these shift just because we have a new tool that we're using or experimenting with. What has changed, though, are the conditions under which we're exercising our clinical authority. So AI introduces what's called influence, right? When a system generates, say, a risk score or a treatment suggestion or a documentation summary, it carries cognitive weight. And even if we think we're critically evaluating it, that algorithmic output can subtly shape our perception. And so over time, authority can migrate, and it usually does so quietly and sometimes in invisible ways. And we're going to talk more specifically in just a moment about this. But it migrates from clinician judgment to system recommendation. And there's real risk in it. So risk then starts to live in over-reliance on the system. It lives in automation bias, in deference to an opaque system. And we're gonna talk about how we start to manage that. Because ultimately, managing AI risk is about safeguarding where the center of judgment lives. And by that, I mean our clinical authority. If the clinical authority lives with you, the licensed practitioner, it can be informed by the tool, but not displaced by it, right? Then our ethical foundation holds solid. And we can safeguard our clients. Now, when we talk, or I know certainly when I do, and maybe we'll hear if Donna has a similar experience or not, but usually I hear clinicians tend to fall in one extreme or the other, right? There's fear on one end and hype on the other end. So the fears about AI, right? That it's going to replace clinicians, that it's going to erode the therapeutic alliance or relationship, that it's going to start acting without clinician oversight. Well, hopefully we're going to stop that one, right? We'll talk about that. But there's often an assumption of full displacement. And I think a lot of these fears, while understandable, they overestimate technology and underestimate our professional structures. Granted, technology is changing, so we'll see where it heads. The other side, though, right, is the hype. This is sort of these claims where AI is going to fix everything. It's going to make the perfect world. It's going to dramatically improve outcomes and make decision-making objective and neutral free or value free, you know, all these things that probably also aren't going to happen. That neither one of these extremes are true, right? Both of them distort reality, just in opposite directions. Reality, though, is more nuanced. Now, one thing I do want to say, AI isn't just another tool, right? It's not like, oh, now I have an automated scheduler, or now I have, you know, Microsoft Word. You know, before Microsoft Word existed, we were like, oh, it's great. Look at how great this is, right? It's different. AI really functions as an interactive thinking aid. Some people are calling it a co-pilot or a cognitive thinking partner. It's a thinking system. Now, it's not a human thinking system, but it's a thinking system. And so it participates in that process with us, and it can influence our own thinking. So risk then becomes not so much are we using it or not using it, but how are we using it? And that's the important thing. We'll talk a lot about how ethical use is going to be determined by context, role, and risk level, not necessarily the fact that it's new. Okay. Donna, over to you.
Let's start with a little bit of an understanding of your comfort level now that we know what it is that your focus, your lens likely is to be primarily clinically focused. Many of us over the last couple of years have done a deep dive into tools and resources and understanding some of the basis of AI in clinical practice and feel a little more comfortable, at least from a knowledge perspective. Some of us have put it to work and tested it, and others have just stayed on the edges, looking out for what might be the best choice for us as we navigate this new transition. As Liesl mentioned, oftentimes we are at those extremes, either this fear that AI is going to replace us as clinicians entirely, or some type of evangelical optimism that AI will solve all the problems that have been plaguing us over years. And neither perspective is going to serve us very well in this conversation, because the reality is way more nuanced. AI is a tool, and like any tool, its ethical implications are going to depend entirely on how it's used. As a tool, it has no perspective or feeling, it's agnostic. It is us using the tool that give it a direction and a scope, and how we use it, who uses it, and probably the most important to this discussion, in what context. So Liesl and I, again, we're not here to be anti-AI or pro-AI. I've been using AI as part of my training clinic for a number of years, but in a very contained way and a very small tool. But we are here to be pro-judgment. Use your clinical and your otherwise good judgment to make decisions. Have a calibrated level of confidence so we can use the tools, but also what we're looking for is something along the lines of epistemic humility, which is when we know that we need to know what we don't know. That we treat epistemic humility and the lack of knowledge as a safety issue. That's not a something that is a slight to us. It is not counter to your intellect. It is simply we don't know what we don't know yet, and we know that we need to know more. So let's take a look at what y'all said in terms of your comfort level. And for the most part, we straddle that line, and this is fairly typical for audiences this day and age in talking about this topic, that we straddle the line of not very comfortable and somewhat comfortable. There's very few of us that tend to be very comfortable, and I think less and less that just aren't sure and are extremely uncomfortable still. But I appreciate the I need more information answer, because I think that is true for almost everything that we're talking about today. It is impossible in this current timeline to have all the information, because the information is constantly updating and changing. We were talking about, in preparation of this webinar, how often people want to know about particular tools or AI systems. It's really hard to discuss that, because by the time you talk about a tool, it's evolved, it's disappeared, it's been found not to be good anymore. So this isn't to endorse any particular tool or approach. It's, again, back to endorsing good judgment, epistemic humility, disciplined caution. So what does humility really look like? How do we put this into action? Having our pause points, knowing that it is up to us to determine appropriateness, safety, and ethical implications before we take a tool that may seem very high quality and helpful for what we're doing. But if we're going to integrate it into any form of patient care, which is high risk enough, but into high stakes decisions surrounding patient care, then we need a pause point. This is where consulting with colleagues, with others in the field, not just with the vendor and the AI optimists, if you will. Understanding that AI works from a probability perspective. Even our best current levels of generative and conversational AI, they have knowledge, but they don't have wisdom. Your clinical wisdom will always be an important factor to any probability knowledge that an LLM or an agent can provide. Understanding the rationale and the limitations for any tool and behind any output before using it. So I need to be able to easily explain anything I'm intending to use, not just to a patient, but to my colleagues, to my supervisees, to my office staff. It needs to be something I understand fully and is explainable to make sure that I have both transparency and accountability. Humility really looks like slowing down when something feels a little too easy. And I have to admit, when the early days of treatment planning and progress note help came about as the result of AI, that felt really easy to those of us that have been working from scratch to generate those. So slowing down and looking at where's this coming from? What is it not capturing? And what is it that I want to say versus what this product is trying to say? Having that accountability, transparency, but also looking outside of just my closed loop of a system and talking to someone in a supervisory or consultative way for anything I'm going to use. And like any ethical decision, documenting its use, not just from an informed consent, which we'll talk about in great detail later on, but also the choice to use a tool. I should document my decision and my rationale around that and how it's used and what it produces so that I have thorough transparency, but also a key concept that we'll touch on in a bit, defensibility. So the hope being that you're coming away with, and I'm open to AI, but I'm not going to outsource my judgment to AI. Looking at the distinction amongst platforms, as well as the distinction between what can AI do versus what do I do, will be essential in making these decisions to practice ethically. We have to have real precision in how we think about these tools. We cannot blur these distinctions because that will blur our judgment. So your mental checklist, if you will, prediction versus understanding. Pattern detection is not clinical comprehension. AI can guess well, but it doesn't understand. You as clinician understand context, culture, meaning in ways that AI does not. Apparent intelligence versus clinical competency. Fluency in the language of what we're doing looks like expertise, but it is not. Confidence, which AI has in abundance, is not competence. User experience versus the system intent. We run into this a lot in our own lives where we see a tool or we are using something new in our own lives that's supposed to do something, but it just doesn't work for us in the way that we wanted it to. What feels supported or supportive may be optimized for engagement and retention, not really about outcomes. So it may feel better to the end user than it actually is for the end user. And then what's the difference between, say, general purpose generative AI and a wellness app that might be more of a self-help variety, or a tool that a provider might suggest to a patient? These aren't interchangeable categories at all. The data protections differ wildly among them, and our professional obligation differs wildly as well. So the stance that we take is approach this with a sense of calibrated unease. We want you to be vigilant, but not so fearful that you become paralyzed.
Yeah, exactly. And one thing I'll add, I mean, those are all great points. And I think we also want to add here is don't do this alone. right? There is a lot to know. And so we'll talk about consultation later, but this is an area where we need to be learning and consulting frequently. And we'll come back to that. But I wanted to say it here because it's also a way that we can, I think, support ourselves in the challenge. This is a challenge and we need to take it up and see that, and we can meet it with some strength, I think. So we want to turn now to this concept of ethical drift and authority transfer. And this is one of the primary fault lines, so to speak, right? To go back to our metaphor there. So I'm going to sort of give you some dense information on this, and then we'll soften it in just a few minutes and give you some practical understanding as well, too. But really, the central risk with AI is not that AI becomes super powerful. AI is already very, very powerful, right? It's that authority begins to move, in particular, without us noticing it. So ethical erosion or drift rarely happens with dramatic handoffs. It usually happens through this gradual cognitive reliance. We don't have to formally hand over authority for it to shift, right? When a tool consistently frames the options given to us, or summarizes cases, or generates formulations, it begins shaping how we think. However subtly, it is shaping that, even if we are making that final decision. Liability, ethical responsibility, of course, remain with us. Even if those upstream thinking is influenced by tools, we're still absolutely responsible. So our responsibility doesn't diffuse just because we're quote unquote sharing influence with AI, right? That AI is sort of influencing us in a way. And things like bias, documentation errors, over-reliance, all of these become amplified when our authority is ambiguously located. So I loved what Donna said a minute ago about we have to really have precision with these tools. And we need to be very precise about where is our authority and judgment located. So one of the things we want to always be asking is, who is leading the thinking? And in particular, who is leading that thinking over time? This is not a one-time isolated use. It's a cumulative influence. Over time, repeated reliance actually can reposition where that insight originates and where evaluation happens. And so risk will increase then when that influence is not visible. That's the most dangerous thing. And I think a lot of this can come, that's why sort of educating ourselves is really important, because when we use AI tools without recognizing this, the risk for this invisible force is all the greater. And it becomes much harder to critically evaluate the impact of AI and where the risk is, right? So the primary practical risk management question I think we have is, where is authority sitting when I use these tools? It's not whether the tool is advanced or not, but whether our clinical judgment remains centered with us, right? So I think sometimes it's helpful to have visuals, and this is the visual of the drift pathway, right? How does it happen? Well, we initially begin using AI as assistance of some kind, right? Supports efficiency or organization in our workflow, those kinds of things. Maybe we're using AI to organize material or to brainstorm phrasing or various things. At this stage, the authority is pretty clearly with us, right? AI is just the quote unquote assistant. But over time, assistance becomes reliance, right? Sort of this idea of it saved time, it worked well last time, so I'm going to do it again. And now we have these repeated experiences, possibly positive, right? Where we feel like, oh, AI got that right, great. It's helping me in my workflow is going better, it's super efficient, it's all good. And then the tool starts to become the default starting point rather than that occasional assistant. And then it shifts a little bit further. AI outputs increasingly start to frame options. They start to frame the priorities. They start to order, what do we think about? What questions do we ask? What interpretations are possible? Now here, the clinician is still deciding, quote unquote, but is increasingly making those judgments within the contours of AI-generated material. So it's not even the clinician's full thinking, it's within this AI system. And so the cognitive starting point subtly shifts from origination of an idea or interpretation to evaluation of that idea, right? And then authority transfers. Clinical judgment is still exercised, but it's exercised within AI-shaped boundaries. So there's no longer explicit delegation. The authority is migrated incrementally and usually invisibly through this habituated reliance. So that's sort of the pathway. And I think one helpful question to ask for those of you who are using AI now, just reflect for yourself, where might that drift already be happening? And I will say, certainly this drift happens when we're using it in clinical situations, but it also happens when we're using it in our own personal lives, and I think we all can have experiences with ChatGPT where we can start to be like, oh, that's, and you have to sort of tell it, no, don't do that. We have to take back our own authority. So drift can happen in lots of different ways. Now, authority does not shift in the moment of a final decision, right? It shifts in what consistently captures attention and defines what seems salient. So over time, the source that frames the options, right, that gets to decide what's relevant, what's worth considering, that's where it begins to accumulate cognitive weight. And that's what I mean here on this slide when I talk about center of gravity, right? A clinician may still make the final call. Nothing has been formally delegated, but influence is already shifting in the thinking process, right? In terms of how cases are summarized, what risks are highlighted, what interpretations are brought to the foreground versus the background. That's the upstream movement. So in this image here on the right, AI defines the starting framework, and the clinician is reacting from within that framework. So although technically control remains human, the framing has shifted, okay? And that's the problem. If AI output becomes the starting point, clinical reasoning can become evaluative rather than generative, meaning instead of asking what's happening here, we're saying, do I agree with the AI summary? Those are two very different questions and very different centers of gravity. And that's where the authority starts to drift. So the ethical question is not simply who makes the final decision, me or AI. It's really who is shaping that decision, who is shaping the menu of possibilities, who defined what counted as relevant. And this will become important too later when we talk about bias and some other things. So drift, of course, is incremental. It rarely happens in a visible handoff, right? We don't hand it over to AI and say, here you go. Each step along the way in that drift pathway, it feels reasonable. It feels justified in the moment. And there's no obvious point where we're like, oh, I'm giving this over to AI. And that's what makes it really hard to see. Benefits like efficiency, clarity, reduced cognitive load, they reinforce the use of AI. It feels good. Oh, this was easier. What would have taken me 2 hours took me 1. Yay, this is fabulous, right? All of that's really good and reinforcing. The short-term gains are visible and tangible. The long-term framing shifts are slower and less perceptible. When AI outputs are accurate and helpful, our scrutiny of them naturally decreases, right? We're like, oh yeah, that is what happened. If we're, say, an AI documentation tool, when we read it, we're like, that's a great summary of a session. That's perfectly accurate. So our scrutiny decreases. We start to just trust it more. Repeated success becomes kind of implicit evidence of reliability, and then it accumulates more trust. However, we know that AI is wrong. AI hallucinates. So that is problematic. By the time we consciously notice reliance, the patterns are already in place, right? That influence has built gradually, like the magnet here, pulling those filings before it becomes visible as drift. Responsibility does not adjust based on awareness. So even if influence shifted gradually or invisibly, ethical and legal accountability remains with us, the clinician, always. The professional vulnerability is this, that you actually can be held responsible for a judgment that you actually may not have originated. and may not even be fully aware of how you got to that judgment, depending on the opacity of the system. If the AI shaped the starting frame, your final decision, you may feel like it's your decision, but it didn't come from your independent reasoning, and you may not be able to articulate that.
I think it's also important to note that, later we'll talk a bit about how this is emerging, this drift is emerging in lawsuits and the legal landscape as our profession will be impacted by other professions that are currently under scrutiny. Our profession is as well, but other professions are really seeing this drift come to a legal head.
Yes, yeah, no, that's a good point, and we are going to get there a little bit later. But you can think about, as we're going through some of these points, because especially later when we talk about some of the risk management pieces, there are places where this poses very real risks for us as clinicians and for the welfare of our clients. And so we need to really be seeing that along the way. And we don't yet know how the law is going to find, what side it's going to come down on. So we'll come back to that in just a few minutes. As I mentioned before, right, the presence of AI is not so much the problem. The tool is not inherently ethical or unethical, right? Risk doesn't reside in the novelty or complexity or even in the capability of AI. The risk emerges in how that tool is positioned within our professional reasoning. So instead of asking, is this tool safe? We want to start asking, how is this tool functioning in my practice, right? Risk, of course, is relational. Depends on what role the tool is playing, what function it's serving, and importantly, what consequences follow from that. The same technology can be used, say, as brainstorming aid, carries a very different risk profile when used to shape a diagnosis or a treatment plan, right? So when we, sort of move down this continuum from the technology to what role it's doing, to what function it's doing, and then very importantly, what is that consequence? That's how the risk emerges. Without role clarity, the risk assessment is categorically incomplete. Okay, we're going to talk more about the role clarity here in just a moment. But before we even evaluate risk, how risky is this? We have to first ask, well, where is the authority sitting? If the authority is clearly sitting with the clinician, then risk can be managed generally. Not all, and we'll talk about which ones, but usually it can be managed. If the authority is diffused or ambiguous or upstream, then you can't really assess risk, right? Risk becomes harder to evaluate and control. And that's, of course, really problematic. If AI is steering the reasoning, certain risks are never going to be in the foreground, right? So ethical analysis then has to begin with this idea of role clarity. So the same AI capability can carry radically different ethical risk, right? There's different ways that AI can show up in our world, right? It can show up in sort of an administrative matter, right? Uses logistics and operations like scheduling, billing, drafting. It can also show up clinically, right? Being involved in it, assessments, formulation, planning. This is where it moves closer to diagnostic reasoning and treatment decisions. And it can also be used relationally, meaning making, right? There's various ways that it involves the therapeutic relationship itself. As AI moves across these domains, the ethical stakes change. So ethical risk scales with proximity to human judgment and the client's psychological life, right? If you're using, say, AI to, draft a policy for your practice or to create an educational tool, that's lower risk, right? But if you're using it to come to a judgment decision, a diagnosis decision about a patient or for risk assessment, that's much higher risk. So the closer that AI gets to shaping interpretation or formulation, that's the higher stakes. And in some ways, I think that also can explain why some clinicians disagree about AI. It's because sometimes they're talking about AI in different roles, and there's some where the role clearly is low risk and some where the role is much higher. So the main thing we want to keep in mind, right, is that the risk increases when it approaches judgment. That's the main thing we wanna really focus on. Now, before we go further, I do want to pause because I know sometimes people get really anxious. So this slide is for all of us, myself included sometimes. I'm moving forward, but I used to really want to remind myself that I don't have to adopt AI, right? So if you're feeling nervous, that's okay. You can simply not choose to use it right now. Non-adoption at this moment in time can absolutely be ethically appropriate. Sometimes, in fact, restraint is good professional judgment. And we'll talk about some forms of AI that maybe we should hold off on right now. Always context is going to be important. So yes, you can choose to not adopt it. What you cannot choose to do at this day and age, given where we are, is we cannot choose to ignore it. We cannot choose to sort of be illiterate about it. We have to learn about it. We have to know what's happening because, again, it's impacting you right now, whether you think it is or not. And importantly, it's impacting your clients, right? So adoption is optional. Professional awareness is absolutely not. We have passed the stage where professional awareness would be optional. That's no longer the case. But there may be times, and we'll get to this a little bit more at the end, in certain situations like, you know, limited evidence or opaque systems, those kinds of things, where yes, you would want to have restraint. So that was a slide for those of you who think, I don't want to do this. That's okay. Now, this is the slide for those of you who think, I do want to do this, but I want to do it carefully. So how do we do that? This is sort of the beginning of a role-informed clinical ethical judgment framework. And it has 2 steps, but they're big steps. So the first step, and we're giving this to you as a tool because we want you to have something to take home to use when you're thinking about these decisions, right? The first one is you've got to name the role. So before we can ever evaluate whether something's ethical or not, we have to know, what are we asking the tool to do? And there's a lot of roles we can ask AI to do. And all of these carry slightly different risks, right? Administrative support might be low risk, depending on what kind of support that is. We'll see later that some of the AI documentation tools probably are not as low risk as people like to hope they are. Cognitive support, you know, clinical reasoning. As you get up, again, as we move towards greater and greater judgment, we see higher risk. So you first want to know what's the role. The second step then, and this is a little, can be a little heavy, is we've got to ask a lot of questions, right? And you'll see in this step, and I'm going to walk through some of them, and each question has its own questions underneath that, right? And we don't have time to fully unpack this, but this will give you a very good starting place. Some of these questions may be uncomfortable or overwhelming. And you know what? If that's your sense, then you're right at the sweet spot, because that's where the risk lies. Risk lies in places where, you know, it's unclear or we're uncomfortable. So the first question is, what kind of judgment is being asked of you? Is it technical judgment, clinical judgment, legal, so forth, right? Are you interpreting meaning? Are you weighing values, assessing risk? AI can assist in technical judgment. It cannot assist or sort of own moral or professional judgment. Who or what could be affected? Your next set of questions, right? Client safety, therapeutic alliance, confidentiality or privacy, documentation discoverability, future board review, your professional identity. There's a lot of issues here. And it's very important that you think longitudinally, not just what will happen today, but how does this look a year from now, 5 years from now, right? What safeguards are required? And this is really important. We'll talk some about this later, but some example safeguards might be de-identification. However, I want to put a big asterisk on that. We're going to come back and talk about that because de-identification is not as safe as most people think it is. But what kind of safeguards do need to be put into place so that we can make the use intentional rather than reactive? Can you clearly explain and defend your choice? You know, can you explain and defend it to a client in language they can understand, to a licensing board, to a court, to your supervisor? Are you going to feel comfortable with this decision today, 2 months, a year? And if your explanations to yourself feel vague, well, that's data, and very important data. And it may suggest that you need to pause or get some consultation. And then the last question here, how would you reason through this decision if you didn't have AI? This is not about purity, right? It's about authorship. If the tool disappeared tomorrow, can you still reconstruct your independent reasoning? Is that, and I think Donna's used the word wisdom. Do you still have that wisdom, or are you relying only on the AI's quote unquote knowledge? So if we apply this framework, what happens is that risk can become more visible to us. So if we think that in sort of three circles, we've got role, right? What function is the AI tool playing? We've got context. What are the stakes and vulnerabilities in the situation? And we've got judgment. What kind of professional authority is being exercised? And the risk visibility is right there in the center, right? If you move one of these circles, of course, the center changes. So risk really becomes visible through role and judgment. And part of judgment is the context. As I said, there may be some sort of low gravity areas where using AI with appropriate safeguards is perfectly fine and helpful. When there are, higher risk situations, clinical reasoning, relational involvement, decision shaping, or recording of sessions for AI notes, there's huge privacy issues there. Then our scrutiny has to increase, right? So higher risk means slowing our thinking and maybe pausing for a bit, depending on what the situation is. Okay, on that note, oh, right. I did want to give you a slide here. So when might you want to avoid using AI? What are the red flags that would say, yeah, I'm not going to do that right now in this context, in that role? Well, here's a list of them. And of course, we can't make this exhaustive, but here's the big red flags to look at. First of all, if evidence is limited in high judgment domains. So as AI tools move closer to formulation, diagnosis, risk assessment, the evidentiary bar rises, right? Many tools have validation in administrative or workflow contexts, but they don't have strong empirical support in areas where where psychological judgment carries weight. And their caution is not fear, it's actually proportionality, right? And that's important. Also, if you cannot explain how a system reached a conclusion, then you are accepting influence that you cannot interrogate, that you cannot understand. And opaque systems concentrate that responsibility in you, the clinician, but in a way that you can't understand and determine how it's influenced, right? So when there's opacity, your duty of scrutiny actually increases. You have to lean in more and learn more. If you cannot understand a system well enough to defend it and articulate that defense, then restraint is likely warranted. We are practicing, as we've talked about, in a moving regulatory landscape, right? State laws are evolving, case law has not stabilized. There are lawsuits now against providers who've been using AI. None of them have, to the best of my knowledge, none of them have ended, so we don't know what the outcome is. But, none of us wants to be that test case either. So we need to be really, really thoughtful. And when, doing early adoption in unsettled territory carries heightened professional exposure. So sometimes restraint in that regard is not not problematic, right? It might actually be regulatory realism and protective of our clients. Also, and this gets back to that data life cycle, I think both Donna and I have talked about now. If you cannot clearly verify how data is collected, stored, shared, encrypted, retained, particularly any use of PHI, that is not a minor issue. In fact, that is very, very, very big. Confidentiality, of course, is not an optional value in our work. So you also, and we'll get to this too, you cannot simply rely on a vendor claim, right? I guarantee you, if you go to a vendor website, they're going to tell you how amazing their product is. And they're probably going to say, oh, it's HIPAA compliant. Great, right? So I can use it. No, that's the beginning point. That is not the ending point. And then lastly, if you find yourself unable to distinguish your reasoning from the tool's output, then your authority may already be drifting, And that can be a problem. So these are some of the red flags that that should sort of point in the direction of, hey, you should pause here, and maybe get some more consultation before you use AI in these instances. Donna, over to you.
What I think is a common theme I hope y'all are hearing is that the use of AI is an ethical decision like any other ethical decision that you're going to make in your practice. And so doing it in isolation is never going to be the best approach. Having someone that you can consult with that's not just the vendor, their job is to sell you the product, and getting your own training, keeping yourself up to date on what is emerging in trends, in models, in types of products is one of the few ways that we have to approach this work ethically in a landscape we've never been on before. So I want to talk a little bit about the continuum of products, which also is a continuum of risk as we move from purely administrative types of tools to those that we would consider to be clinical adjacent, to those that are more directly applied in a clinical setting, and then autonomous mental health tools, which may not intersect with you in practice or that the client may bring into your work in practice. And this is not about whether the tool is good. Risk is about proximity to judgment, and it is the closer it gets to clinical decision making. That's where we need more scrutiny. So I'm going to ask you to take a moment, and if you are using any tools, share with us any of the products or types that you are currently using that have some AI to them. I think almost all of us probably have some form of AI embedded email. I know that even the strictest platforms for practice and or academia or corporate world are building some closed loop AIs to help draft your email, finish your sentences, etc. So many of us are already touching AI in that way, but there may be other administrative or even clinical adjacent tools that you're already using, or some that are helping to support some of your direct clinical work. It's just helpful if we kind of have a sense of that. And as you are responding to those various points, let's consider that lowest of the risk continuum, which is still risk. So even administrative AI being the lower end of the risk continuum is not an absence of risk. It is a level of risk that must be assumed and understood if we're going to use these kinds of products. So, these are our scheduling and calendar type products, those that help us with very routine, non-clinical, non-patient data correspondence, and those that maybe are helping to automate some of our billing and claims, which I think are really helpful and emerging trending uses of AI in clinical practice, but not required. All of this could be done completely without any technology, much less AI. And go ahead and end our poll, and we'll take a look at what folks are using, the composition of document emails or messages, using an EHR that has AI, some support within. Some of you are getting those progress note drafts. Some of you are getting some report drafts. Some of you are getting or using on your website conversational chat agents. And there's a lot of this that parallels work that we've always, well, I say always, not always, because I'm older, had in our clinical practice, where we've had, say, the generation of an assessment report that was automated, but that report was not converted to a patient psychological report. That was information for us to use in order to generate a report. AI can give us some of that same type of feedback, but we have a much higher responsibility to managing the risk because now we're using a different type of model to get that prediction. So administrative use for AI is often our safest entry point, if you will, even if these don't always touch PHI. So workflow, billing, non-clinical, but even here we have to confirm what's being stored, where, when, what identifiers might be present. So I'll stop sharing our poll and then we'll take a look at sort of our next level of risk, which is clinical adjacent. So here is where we're seeing things where we may get a little bit surprised because the tool feels sort of minor, but it can behind the scenes begin to shape records. It can shape even our thinking. It can begin to influence our judgment if we're not paying attention. So the two biggest categories of these clinical adjacent AI products are those that do psychoeducation drafting. So creating maybe a more personalized set of psychoeducation for a patient than you might ordinarily deploy, and as a documentation aid. So going back to that progress note, drafting, treatment plans, suggesting, we see AI being used in those systems because that's what it's best at. It's best at taking a large bank of knowledge and giving you ideas from that large bank of knowledge objectively and without becoming fatigued. As humans, we have our own sets of biases, which, my goodness, we'll get into AI bias in a minute. There's a ton there. But from a pure fatigue bias or interpersonal bias that we could have that could show up, sometimes AI is a nice balance for us in that it could provide us with some messaging or thoughts, ideas, what it sees. Again, it's not human, so it doesn't see anything, but it may share with us things that would be appropriate for documentation. But we have to look at that privacy risk. Where did that data come from to inform the documentation? Did it come from audio or video recorded sessions? What is happening with that data? So this category requires pretty high oversight, even when it feels like something very low effort. Then we move into a category.
Donna, can I just add real quick?
Yeah.
I just wanted to add. So when you say, I think it's really important, and you were getting at it there a little, the clinical adjacent documentation aid, which currently says it's low oversight needed. I want to just add a slight subtle distinction. It's one thing if you use an AI agent and you give no PHI, right? You pull up ChatGPT and say, if I had a 20-year-old person who had these 3 symptoms, what might I need to be thinking about, right? 0 PHI put in at all. You're not even describing your patient.
Right.
You're just that is indeed low risk, low oversight needed. However, and we're going to talk about this later, but because I want to make sure the slide doesn't misstate this,
Sure.
A documentation aid or an AI tool where AI is recording your session and summarizing a note, in my opinion, that is absolutely not a low oversight needed place. That is a high oversight needed. And we'll talk more about it, but I just wanted to make sure
Sure.
the slide doesn't misguide us there. So
yeah, and any time that you're using actual content from a session, you are at high risk, period, the end. There is no way around that because you have then taken something that heretofore would be considered a very private activity unless you, the clinician, chose to move some content out of that due to duty to warn or writing a progress note. Now we're using recordings to help confirm what happened in sessions and generate those starter notes. So it is much higher risk. Even higher is if we move into direct clinical work, where we are using AI as a diagnostic support aid, or in treatment planning more than the progress note, this is even higher, or what I think is absolutely the highest risk, which is clinical safety and risk management. If AI is flagging communications or progress or treatment summaries for risk and reporting that back in some way, then we have outsourced clinical judgment related to risk. And that is not something that we ever want to outsource. I think there can be some utility in having a backup so that we don't miss risk, but we cannot rely on something that is not us to assess risk. Anytime AI is going to directly shape the care of the patient, we are at high risk. We are in the zone where any mistake could cause harm. And harm to our patients is what we are trying to avoid. The only time we want to use a supportive tool is to benefit the patient, either directly because somehow it benefits their progress towards their goals, or indirectly because it benefits their provider to be a better provider to them. Then the highest of all risk is unfortunately something that you may not have any insight into. And that is the autonomous AI platform or app that is being used by your patient with or without you. So using an autonomous platform intentionally in psychotherapy requires extreme caution. It is a high risk endeavor. What we're seeing more often is our patients using it without our involvement and without our insight or oversight or assistance. These autonomous clinical products really collide with our standard of care and our ethics that requires us to be the primary source of treatment. We'll see later on today, there's some states that have taken this on in legislation and said that providers may not offer these to the citizens of their states. And if a provider uses anything similar, it has to be only a licensed psychologist, not someone who is providing some form of support care. In most psychotherapy contexts, this type of autonomy is not going to happen, and this type of automation is not going to happen. It's a liability. So it will be more likely something you find out from your patient. Where do we see it most of the time happening? We see these assisted documentation services. We've had technology involved in documentation since I've been part of the profession, with recording our progress notes and sending microcassettes. I'm really dating myself, off to transcriptionists who would type up our progress notes and treatment plans. And there was risk inherent there as well, because not always was the transcriptionist present in the agency. And so you had transportation of the cassette risk. You had potential error risk. You had to have a clinician oversight to review what was dictated and ensure that it was accurate. And the dictation may not come back for review for weeks. And so you hit risk there as well. We do see AI in some clinical decision support, but it cannot be the sole use of clinical decision making. The pattern detection that it's good at may be beneficial to us looking at clinical decision support platforms. Sometimes they're built into practice management. I would imagine those of you that indicated you're using some AI, that some of you got into it because your practice management system, your EHR, embedded an AI option. But my guess is also that you have the ability to opt out of using that particular feature within the platform. We see our clients gravitating, we see our families, we see our friends, we probably even see us gravitating to apps and chatbots that benefit our mental health or wellness. My Apple Watch reminds me of my wellness all the time and has AI components built into that. But it's different when we are the ones providing it or even recommending it. So that is something that we'll see more in the marketplace, and we need to be very well informed about what our clients and our patients may be using. And that is separate from anything that we might actually recommend that someone use. The last place where we see AI really showing up is in this external recording and analysis that happens in some EHRs. That's how the progress note draft gets written, but also happens when our patients are recording sessions on their own or analyzing their own therapy content because they have recorded with or without your knowledge or permission. So where do we see it? What counts? Now let's look at it from a platform perspective. Generative AI is the type of AI that generates text by prediction of what would the next word would be. So you're really going to see generative AI in those drafts of emails or progress notes. Predictive AI is better suited towards things like catching patterns, risk flags, assessment analysis, but also content analysis of sessions looking for risk and patterns. Embedded AI we see in our EHRs, and they're often very invisible, and that is on us to understand what they are and if they're enabled in our particular product line or not. And then the client side that they bring into therapy are most likely going to be generative and conversational AI types of apps. The different categories have different risks and different levels of consent. So we're going to switch things up a little bit here in the webinar and actually enable the chat, not just the Q&A, so that you go ahead.
So I'm wondering, I'm noticing our time, we've got about 15 minutes before break.
Yeah.
So I'm actually wondering if we need to let's maybe pause the case example now, see if we can get through the slides and then come back to this if there's time before the break.
You bet. Let's move on then to talking about the real harm that we see in confidentiality, privacy, and what can happen with these tools. So going back to our seismic metaphor, something that happens with earthquake-prone area is something called liquefaction, and that's when the ground looks very stable, but because of the pressure, it is not stable. And that's where we really are right now. These privacy risks are often invisible until something goes wrong. So we have a privacy breach, or we get a subpoena or something. Looking at confidentiality and data privacy, it is our responsibility to map the full path of data storage. Now, this is what caused me to have to learn terms and technology that I was not aware of as a practicing clinician, and as someone who is not a computer scientist or coder, had very limited understanding of. So not only where is the data stored, oh, it's on a server, it's on a cloud, but where on my device, when does it leave my device, where is the backup, how is it logged, and does it cross jurisdictions, which is that second piece here of who owns it. The vendor owns it, but it's also maybe stored on a cloud. Who owns that cloud? Not just the company, but the country in which the cloud is sitting. A huge question that we have to ask our vendors is the data used for model training? Most new vendors hope to train their model on data. We're in the infancy of this phenomenon of AI. There's not enough data to fully inform the models. So getting your data is a real boon to these vendors. And a recent court case is likely going to change your willingness to do that for model training. And then what is HIPAA alignment. How does that even relate to us? What does it take to truly be HIPAA compliant? And or is it really just consumer technology that's not intended for PHI at all? So if we look at sort of the downflow of how data could be used and stored and identified, we have to look at three areas. Profiling is the data that is used to predict what happens next, the risk level, the diagnosis, anything that is categorizing the individuals using this tool or that the tool content is about in that profiling stage of things can be inaccurate. So even inaccurate data will start to shape decisions, access to services, insurance, claims denial. Then we have to look at secondary use, where those vendors are using data that's greater than what the client thinks they've consented to. So you, as the client of the vendor, need to know if it's being shared with subcontractors or processors, being merged with other data sets. Are they selling aggregate insights to other vendors? And you, as the client of the vendor, disclosed for a certain purpose. Your patients disclosed for care, not these secondary uses. All right, and then re-identification. So re-identification is when something gets labeled de-identified, but could still be linked back. And we see this a lot in small or niche communities when intersectionalities are very clearly defined and only in certain places or areas. Then we could see that re-identification occurring, which is a violation of what your client has agreed to and what you have agreed to. Then we have to look at how's the data stored and collected, which we call the life cycle of the data. So once data enters into the AI ecosystem, even if it is a closed loop, you're not putting it into OpenAI, ChatGPT, you've bought a proprietary program, it's a closed loop system, there's still a life cycle of that data that causes control to be diminished over time and stage. So there's the initial collection, then there's where and how it's stored or encrypted. Is it encrypted at rest, in transit, both? Retention of the data, data used for training, and then the dreaded sharing and reselling of data. We have to know what is going on with the data of our patients at each and every possible stage before agreeing to use something that would be a tool embedded with AI. And then finally, for me, and Lisa, I think you have some thoughts as well, this idea of confidentiality and invisible harm. These consumer AI tools, these general purpose chatbots, they're not HIPAA compliant, HIPAA aligned, and some may even portend to be by having a BAA, but all BAAs are not created equal. Knowing what a BAA needs to include in order for you to justify and verify HIPAA compliance, that falls on us. Removing names does not equal anonymity. Context, those details, timestamps, even your identifier will create identification. Looking closely at all of the data, how data can become someone else's asset, and then recognizing that our patients are going to make different choices in their disclosures based on whether they're talking to us or whether they are talking to their preferred AI chatbot. And we may see that our patients are disclosing more with a bot than with us. So if that's happening, that's likely going straight into commercial data ecosystems in a ways that our patient is not being protected. And we have an ethical responsibility to help them understand that. Lisa.
Just to add a couple of things. I mean, you make such very important points there, Donna. And One, I think at this point, and eventually I think we're going to need to start including this in our informed consent language, which is the very next section we're going into. But if your patients are using, you want to start asking your patients, are you using AI? Are you using a chatbot? How are you using it? Are you putting in your data to get whatever they're doing, right? Are you using it to record our sessions and get feedback without my knowing? So at this point, I actually think all clinicians should have a paragraph in their informed consent document that invites patients to talk to you about this stuff. Of course, that means we have to be competent in that conversation. So there's some other pieces there, but I think that's really critical. The other piece I want to just note before I talk about AI documentation tools is that de-identification. Remember that de-identification largely is defined under HIPAA. And that got defined under HIPAA years and years ago, well before AI. So the two standards under HIPAA for de-identification, safe harbor and expert determination, they're not, I mean, they're all we have, but they don't necessarily hold up under the power of AI. And that is critical for us as practitioners to understand and to take safeguards. So it is not enough for someone to say, oh, the information's de-identified. That's old days. That's back in 5 years ago when we could say, oh, it's de-identified, fine, we're safe. You cannot assume safety now just because someone says it's de-identified. So I think that's really important to hold on to. And I do for a moment want to talk, I'm going to keep the pace up here because I'm aware of time, but I want to talk about the AI documentation tools in particular. And here what I mean are the tools that record your sessions and write a summary note for you. That's what I'm talking about very explicitly. There are some real potential risks in a couple different directions. First of all, of course, we've talked about this. We always have to ask, is it necessary at all? Now, of course, a lot of us want the efficiency that comes from these notes. So that's sort of the specific problem. But if the primary benefit is speed, and that comes against the risk of permanent exposure of patient data, then that benefit may not outweigh the risk. We have to give very, very serious thought to that, because efficiency alone is not sufficient justification for expanding psychotherapy data exposure, right? As Donna just talked about, we've got to understand that life cycle clarity. And I will say, when I talk with practitioners, this is where many of them have no idea. When I say, who stores your data? I don't know. How do I find that out? You know, we have to know this. If you're using AI, it's essential that you understand this life cycle of where the data is. So where does it go?
And the language, don't you think, Lisa? So much of this, it's a language that's foreign to us because this has not been part of our training historically. Most of us have been around longer in the profession than AI, so we don't have this language.
No, we don't have, and this is, we'll talk about competency later, but this is a huge part about getting competent. It still sort of makes me laugh a little to myself that I'm teaching today on AI, because historically I've been like not understanding technology, but I've now spent weeks and months and a lot of, going to trainings and reading and digging. Like we've got to educate ourselves. It has to become part of our language, right? And not just sort of where's the data go, but who's storing it? For how long is it stored? Who has access? Are there backups that are created? What triggers deletion? Is deletion verifiable? Take, for example, the case, let's say that I'm your patient and I'm now getting a divorce and in a high conflict custody battle, and my husband's trying to get access to my mental health records to use against me in court. Well, if my mental health records now contain absolute audio recordings of all of my sessions, that's a much that maybe can be reachable by a court order or by a subpoena. That's a much bigger exposure for me than if you, my clinician, had just written the progress, right? So we need to really be thinking about that. Again, if you can't map the life cycle, you can't assess the risk. In addition, these systems subtly misinterpret tone. They can insert terminology that a patient never used. They may omit nuance. They can generate content that sounds absolutely plausible, but is in fact totally inaccurate. And reviewing a transcript that has been summarized for you is not the same as generating that content yourself. So one of the questions is, can you and I and we reliably detect distortion in emotionally complex material? And if you think about this, right, subtle distortion is far more dangerous than obvious error. So that's really important. And these create records that live forever, right? AI documentation, as I said, may generate verbatim transcripts, metadata, additional discoverable materials that previously didn't exist. Imagine too, let's say you're now defending a board complaint. A patient has alleged something against you, and now the licensing board wants your full verbatim transcripts. That's a lot of potential exposure for you and the patient, right? So we really have to think about this. And then lastly, consent integrity. Consent has to be meaningful, and we're going to talk about that more in just a moment. Some red flags that really warrant pause here. If there is vague BAA language, Donna said earlier, all BAAs are not created equal. That's absolutely true. The problem too, ask yourself, I won't ask for a raise of hands, but ask yourself how many of you have actually read the BAA that any company you're working with has signed. If the answer to that is no, I've not read my BAAs, then you have serious exposure there, because oftentimes the BAAs are protecting the company, not so much you. So just because a company says, yep, I sign a BAA, that does not mean it's safe and secure in the way that you, a practitioner, would want it to be safe and secure. It also doesn't mean it's safe and secure from the patient perspective. Unidentified de-identification methods, we've already talked about that. If your vendor claims de-identification, you have to ask more about that. What does that mean? We talked about the inability to map data storage and deletion. You've got to know about that. If it is using, Donna briefly mentioned this, but if the documentation tool uses your patient PHI to model, to train the program, I think right now you don't want to allow that. And if we have time, we can come back to this. It actually worried me. Donna, you mentioned that most of them opt in and out of this. I think that's true, but I've heard of a couple programs that require that. If you're going to use the AI, they require you to let them do that. And that's awful. I mean, it's, well, I should say it's problematic.
It's dangerous.
Yeah, exactly. And then verbatim transcript storage, again, without necessity. Why does anyone need to hold your verbatim transcript, right? That's not needed. So the point of this slide is just to say, yes, there's real benefit with efficiency and all of that, but there are very, very real risks. So if you are using or contemplating using a documentation tool, please be very careful. Get lots of consultation. And then I did just miss this last one. Very important to allow opt-outs, and we're going to talk about that in just a moment. If you are using a documentation tool, you absolutely have to have a specific and detailed informed consent, which is where we're headed now. So, early warning systems, if we go back to our earthquake metaphor, they exist so that damage can be mitigated, right? So there are ways we can mitigate some of this risk. I know we're right up close to the break. I'm going to try to get in 3 or 4 more slides, and then we'll take the break here in just a moment. So our traditional informed consent, right? The methods were pretty stable. In our long-term practice, right, most of our methods don't shift week to week. The assessment tools we use, our documentation systems, the workflows, they've evolved slowly. And much of what we've been using today will function kind of the same as it will next week and a month from now. That's not the same as AI. AI might function very differently today than it does a month from now. Traditionally, right, our tools have been bounded and identifiable. When I write a progress note, this is old school, right? But if I were to write a progress note in a Microsoft Word document, GASP, right, we know where that goes. It's bounded. If I write a note in an AI system, we don't really know where that goes, right? Influence in our old traditional consent is observable, and it can be revisited because we know when to revisit it, right? Think about when the pandemic hit and we all went to telehealth, we knew we had to revisit informed consent because that was obvious. Everything's changing. With AI, things can change and you won't know. So when we need to revisit consent may not be as obvious. In an AI influenced practice, right, use evolves incrementally. AI systems update sometimes on their own without you knowing. They may start selling to third-party vendors without you knowing. There's lots of things that can happen. Again, it's shaping the way we think. Clients often can't see how AI is participating in care. And sometimes clinicians don't even see it and don't fully see the downstream effects. So all of this means is that there are new demands on informed consent. You must have ongoing disclosure. You must have system transparency and a genuine opt-out. And when I talk about informed consent, this is not a one-time thing, nor is it a signature on a piece of paper, right? This is an ongoing conversation where we as the clinician first have to understand the implications, and then we have to share it with the patient in plain language and let them ask questions about it. At an absolute minimum, and I want to state clearly, this is bare bones. This is not sufficient. It is a starting point. You must include in a meaningful informed consent what AI does and does not do. Scope matters. Clients have to know what the scope is. You have to talk about the benefits and the risk. I've seen some informed consent documents that simply say, I, the provider, use an AI documentation tool. There may be some risk to privacy. Done. That puts the fear of God in me. That is not informed consent. That's not ethical, in my opinion. You've got to talk about benefits and risks concretely so the patient can make an informed decision. You need to talk about how it might shape your documentation and decision-making, and a client needs to know that. Again, the life cycle data that we've talked about, data life cycle, and all of these concerns about privacy. Is the data sold? Is it sold in a quote unquote de-identified way? Who gets to see it? So forth and so on. And then of course, meaningful consent includes the ability to opt out. And opting out, right, in meaningful consent depends really on these structured conditions for choice. So what are those? Well, first, there has to be a genuine ability to say, I don't want to do this, right? I don't want my data in that system. Second, opting out cannot carry penalty or coercion or subtle disadvantage for your patient, right? Third, when AI is embedded in systems, we have to really consider, are feasible alternatives, do they even exist? Sometimes they may not. We have to really think that through. And we need to very carefully attend to power differentials. Clients may, if they feel like this is your standard system, they may feel reluctant to question or decline tools, even though they may want to. So without a meaningful alternative, right, compliance is not, it's just compliance and not autonomy.
Yeah, so let's get into where we see some of our potential awareness gaps. We are all intelligent. It is not about our abilities. It is about, this is a new knowledge experience for us, and we will see some differences. Bias is not a technical detail. It's a justice and safety issue for you to attend to, for all of us to attend to. So we're going to look at this again using that metaphor of our earthquake, that not all neighborhoods are equally impacted by an earthquake, even at the same level. Most AI models are trained predominantly on Western English-speaking majority culture populations. If your patients don't fit that profile, then you're going to have some inaccurate outputs. They're going to be not only inaccurate, they're going to be inappropriate and potentially harmful. Not all communities have access to the tools or the bandwidth to use some of the tools that might be clinically appropriate and might be helpful to the way that you practice. And so it could be a blind spot for us that the benefits may accrue only for those who are already resourced. If you've played around with AI at all, you understand that the way that AI is programmed, the way large language models work with predictions, is pretty sycophantic. It speaks back to the user in a way that to make the user feel good. And so it hypes up the user, it agrees with the user, and the user may not be correct. And that makes the AI hype up things that aren't correct. Or the AI may pull incorrect and inappropriate things and hype that up. And then we see tremendous gaps, of course, gross ability in language and access, that our performance of these tools will diminish along with gaps in access or changes in ability or changes in language from that predominantly Western English speaking language and population. There's lack of cultural neutrality with AI. It cannot be culturally neutral. We know that these algorithms and models were trained on these large swaths of pure internet data that's not representative of truth or an entire cultural expanse. And so the recommendations it provides may seem very objective and confident and be completely subjective and biased. If we treat the outputs as objective, we could actually unknowingly amplify structural bias, especially when it comes to looking at risk, diagnostic, framing, and assumption of norms, all things that we want to be careful for. So a couple of slides to give you some real tactical maneuvers to test any potential product for bias, and what do you do when you find it? First of all, expect bias. Don't be surprised by it. So you're going to first look for unequal or error patterns across your patient groups. You can do that by running any new tool over a set of small simulated cases that vary and look for those false positives, false negatives. Where does it over pathologize one group or misses risk in another? Or is it less coherent or empathic with certain dialects or certain types of people? Then you can test for what we call counterfactual fairness, which is the appearance of equity in spite of the facts that it doesn't exist. So create a paired simulation for the tool and provide one identity marker that is different. There's an example there on your screen. And then look for the differences in risk level, urgency, more stringent or even coercive sounding recommendations that are based solely on identity cues and that don't exist when an identity shifts. You'll see changes to languaging. You'll see words like non-compliant or manipulative, and you won't see it in your other test case. So you're running a little mini experiment with the platform. Then look for evidence from your vendors. Vendors' jobs are to sell. I have not yet met a vendor that didn't have really a personal mental health interest. Like they had someone in their family that had a multiple mental health problem, or they had their own mental health journey. So I think that there's a kind of a good effort behind it all, but the actuality of it is you have to have evidence. If you go to the Toyota dealership, they want to sell you a Toyota. They don't want to sell you any other product, so they're going to tell you why they're better. So look at their words, make sure they're not using the word proprietary to mask the answers that you need. Make sure that you have overall accuracy claims, not pinpoint data set accuracy. And if they have a red flag would be like no ongoing monitoring plan of their own output. So as you go through those ways to look and test for bias, you may find that bias is present. And when you do, pause. Especially if it's a high stakes use, if it has any clinically adjacent care attached to it, or you may just at that point pause all use and limit it to very low risk or not at all. Make sure that you always have some human touch. So you have a human friction safeguard for all potential tools. So if AI can suggest, but I, as the clinician, have to independently justify. And bottom line is, I know that I'm the one that would be held accountable in any legal situation. So I have to be the one to justify. Document what the tool said, why it might be biased, what I decided instead, and escalate to the vendor. If you could give them, 3, 4, 5, up to 10 really clear examples. I asked this, it gave me that. That's great. If they could be de-identified or if the best case if they're simulated clients or patient groups? What are the subgroup differences that you see? What outcomes you're concerned about? Ask them for model version notes, mitigation plan, timeline for updates. If they can't provide that evidence or a fix, it's not fit for your use. Switch tools. Or you could build a safer workflow depending on what you're using it for. If it's a non-clinical, it may be a workflow issue, but for most of us, it's about switching tools at that point. Why would we continue to use something that we have discovered bias in? So I'm going to take a little bit of a shift now. We've been talking about your use of an AI tool and whether or not it's going to be helpful and appropriate for your patients. But what happens when your patients use AI themselves? Because they are. When we look at use cases of just really basic ChatGPT, the dominant use case in the early years was for mental health support. So we are seeing people use not just open access AI, but proprietary apps that they're purchasing on the App Store and Google Play to support their wellness and mental health journey. And maybe that's good. We don't know. We aren't in the rooms where these are developed all the time, but we will be in the room, the therapeutic room, when our patient brings it in. So these are our aftershocks, things that maybe we weren't planning for that come after the earthquake. So the patient uses AI, that is going to disrupt our relationships and our clinical boundaries a little bit, but we need to normalize it. They're going to bring in AI interpretations. Some of our patients will prefer what the AI says to them over what we say to them, or they'll ask us to co-sign what the AI has said. So have that conversation at the beginning of a new therapeutic relationship and ongoing. Compare what you see in the patient to what the AI said to the patient, and explain the difference between AI wisdom, knowledge, which is facts, and wisdom, which is understanding. Humans have wisdom. Technology has facts. You want to try to not end up in a power struggle with your patient over interpretations and what is right. It is likely that if the patient is using something that has been sourced and vetted, that maybe it's giving some good reasoned responses to the patient. But we want to work carefully with that so that we aren't co-signing something that's dangerous for our patients, but we're also not just saying, well, I don't know, that's between you and the chatbot. I can't get involved in that. So have curiosity in your stance. Ask your patients about it. Work together with it. Be respectful, but that doesn't mean that you have to collude with the AI system or work with the AI system. It prevents the power struggles that are going to come up in this new frontier. So let's look at those therapeutic boundaries. We now have therapeutic boundaries that are never ending. So we used to end at the therapeutic hour and then we would see our patient again in 2 weeks. Well, now our patient's going out with maybe something we've actually provided or suggested. Here's a journaling app, here's a meditation app, or here's something that I actually have clinical oversight into, maybe a dashboard where I could see the work you're doing and I want to use this tool with you. That platform's available 24/7. You are not. That can undermine what I've always been taught is the real true work of therapy. And that's what happens between sessions. So it can undermine the tolerating of ambiguity and separation from advice. The lines get blurred then. What's the difference between a supportive AI and therapeutic treatment that you're providing? Wellness branding can look really good to our patients and then actually push forward clinical assistance that it is not intended for or should not be intended for, right? And then the replacement of the human connection. We are seeing a huge transition in our society where AI chatbots are routinely anthropomorphized. People view them as their friend, as their partner, as someone who's caring, when we know they are not human. But can it give the sense of humanity in the way it mimics empathy? It can, but it is not a relationship. But they may use the AI to avoid the therapeutic relationship, because it can simulate that attunement, but it can't do mutual recognition or rupture and repair or accountability, which is so important. So, what do we see then in our patients? This new clinical attachment to chatbots, intense relationships. I have a partner who's doing doing research on the patients who are bringing in AI romantic partners to the therapeutic process, and how is that impacting the clinician as well as what can be done therapeutically. But we lose the ability to tolerate frustration and conflict if we only integrate with AI that's so sycophantic and always so supportive of us. Because of the way things are languaged when they come out of these AI products to our patients, there is what we call the veneer of objectivity. There's no skepticism on the part of our patients. They don't have the same epistemic humility that we are asked to have about this. They can go in wholeheartedly and accept wholeheartedly. And sometimes then it comes to us to help them critically evaluate. That wasn't what we signed up for, but that might be what our therapy becomes in part. And then, of course, the safety concerns that, AI does not follow our code of ethics. And so it can give really terrible advice during a crisis. I was sharing with this team that we recently vetted a potential product in my university clinic, and it gave terrible advice when clients false escalated to try to test the system. It can reinforce the very belief systems that you are trying desperately to help the patient let go of. So assess how they use it, what they're disclosing, and what it's replacing. And at the end of it all, look at how you're going to document it, because your accountability and defensibility is really where it lines up next. Right, Liesl? So I'll let you speak more to that.
Yeah, absolutely. And we are going to pause on the case examples. If we end up with extra time at the end, we'll come back to them. But to Donna's point, I wanted to just mention before moving into documentation, this is all super critical, right? We could have spent a whole day on that topic alone. So we're just touching the surface. But I do, just in terms of a resource, you've got a list of references in your PDF handout. But APA has put out some guidance on how to talk with clients about their use of chatbots and these kinds of things. That guidance is very good, I think. And so if this is new to you, that's a great place to start. We're also the advisory committee. I'm sitting on one of the things we're going to do is creating some do's and don'ts that will be directed toward consumers. Do's and don'ts for these kinds of chatbots and things that you as clinicians can share with your clients to help address some of these issues. And again, we've just touched the surface. There's so many issues in that. Okay, I just wanted to give you some references. Moving on, right, we've talked about consent, we've talked about transparency, we've talked about structural conditions for choice, and now I want to shift into documentation. As we know, documentation does not create clinical authority, but what it does do is it makes your reasoning visible, and that's important. It's important for patient records if and when they need to use them in other contexts. It's also important for when decisions are reviewed. If you're before a licensing committee or a licensing board or a court or that kind of thing. In AI influenced practice, the burden of clarity increases, right? So ethical reasoning, when you're documenting in an AI influenced practice, your reasoning should never be implicit. Remember that old saying, right? If it's not documented, it didn't happen. In AI, though, if it's not documented, it becomes invisible under review, right? You can't see it. Boards do not evaluate your very good intentions. They evaluate your documented reasoning. And so if it's not there, you could really expose yourself to quite a bit of risk. We also, in AI influenced environments, we cannot rely on assumptions about what we might have been thinking about at the time, right? So we've got to really lay this out. AI involvement also, again, increases the need to show our independent judgment. Simply noting that AI was used, not sufficient. The record needs to show how was it used. Did AI generate suggestions? Did it structure or write a draft note? Did it flag risks? Those kinds of things. So context really matters quite a lot. Review also does not center on the tool, right? It centers on you, on your independent reasoning. So it should reflect your reasoning and rationale, not a replication of whatever the AI said or didn't say, right? So it's not about what did AI say, it's about what is your rationale. In terms of safeguards, you also want to be very aware of and documenting, are safeguards applied? If so, what were they? What privacy protections? What human oversight was used? What limits on the use were there? All of that has to be documented. Remember that even, like I said before about the note, also is true with safeguards. Safeguards that are not visible in the record are really hard to demonstrate that you use them later on. So documentation is what shows that the AI was bounded and responsibly managed. And that protects you, and very importantly, it protects your patient, right? It's also, of course, important to document that how you're using the tool and all that is in alignment with standard of care, which is a little tricky because standard of care with AI is developing and morphing and transitioning. So again, this is where we've got to be very thoughtful about how we're engaging. And I think Donna might have mentioned this earlier, but if not, I want to underscore it because I don't think it's in the notes per se. I'm going to talk a little bit about what you must put in there. Again, this is bare bones, but one thing I would do before we ever get to how you document a session, you want to be documenting your research on the AI tools that you're using. So what's the research say? What information did you gather? What was your rationale for why, yes, this does make sense for me to use? And here's how I'm mitigating any risk or adding in safeguards. What's your rationale on the opposite, right? So that's about the tool itself. You should have just a folder somewhere where you keep that information. In terms of what else has to be documented, right? Say if you're writing a session note or however you're using the AIs, what's the role that AI plays? Administrative, cognitive, clinical, decision shaping, all those things. Was it adjunctive? Did it influence your interpretation? What did you weigh, right? So what factors were you weighing? Again, it's not just your decision. Don't document, I did X. You want to say, here are the things I was thinking about when I was considering X. Here's, what alternative considerations were evaluated, what uncertainties were acknowledged. And that's where the authorship of your final decision becomes visible, right? Again, safeguards, what PHI is protected, what did the client consent to or not? That should ideally be in your informed consent. Were any limitations considered? Why is using AI in this context proportional to the context? Why would you not use a lower risk approach if you needed to? Those kinds of things. And again, your documentation reflects your reasoning, not AI output, right? That's really critical. Affirmation that your responsibility was not delegated to the AI system. You want to document that very clearly. And in many instances, like if you're using an AI note, you're going to need to have some language, a documentation tool that creates the note that you review. You're going to need to have some language at the bottom of each and every note that you sign that says something like, this is from an AI, I reviewed it, I considered it, I edited, I changed it, those kinds of things, so that it's clear that your input is getting in there, right? And remember, this is to protect us as clinicians and our patients. Whatever goes in that document, in that record, follows that patient everywhere it goes. So if it's biased, back to what Donna talked about, if it's inaccurate, if, all these things, that can really cause real harm to the people we work with. Now, all of that also leads to a simple but also important question, which is if this decision is being reviewed, say by a licensing board or a lawsuit, court, that kind of thing. Can you show several things? Can you show what you did and did not do, right? It has to make both your actions and your restraint should be visible. Does the record show why you did or did not do it, right? That's that reasoning I just talked about. Does it clearly describe the role that AI played and what the patient was informed about and not informed about, right? What did they consent to? Again, the weighed risks that we've talked about and your basis for accepting, modifying, or rejecting the AI output, right? Can you explain why it was appropriate? If you relied on it, why did you rely on it? If you modified or rejected it, why did you modify or reject it? Right? It's very similar if you think about this in this regard, the AI is to a consultant, right? If I go out and get a consultation on a clinical case and my consultant tells me to think about A, B, and C, I need to come back in my note and say, I thought about that. Here's why I rejected that. Or here's why I accepted that. So we're doing the same thing, right? If you cannot, if the reasoning cannot be clearly articulated independent of the tool, that might be a situation where you want to reconsider use of that tool. So how do we operationalize that visibility? And, first of all, we would recommend that framework we talked about many, many slides ago now. You want to apply that framework before you document, right? Secondly, make sure your independent reasoning is explicit, very explicit, right? You want your record to show where your judgment resided. Make sure that any safeguards and oversight are documented. Did you implement them? How so? Confirm that your authorship is present and that you did not delegate your responsibility, right? So AI can assist you in writing a note or in synthesizing it, but it does not author it. You really want to avoid any copy-paste summaries without contextualization. That's pretty risky. And then finally, if the record is feeling thin or you're worried about your documentation, that's data, right? That's a signal. And I would say that's a signal you want to slow down, maybe revisit the reasoning, strengthen the articulation, and maybe consider whether this AI tool is working or not working. I think defensibility here is not so much about a defensive practice, because sometimes a defensive practice has its own risks, right? I think defensibility is about whether or not your clinical judgment is visible. That's the key point. Now, we wanted to give you a tool, and I will, fair warning, these next two slides are super text heavy. We know it. I'm not even really going to go into detail about them. This is not meant for us to talk through. This is meant to give you a tool. So these are a series of questions you can ask about whatever digital tool you are thinking of using. And you'll see they go through a lot of what we've already talked about. Is there a clear privacy policy? What about data collection transparency? What about the security, right? Encryption at rest and in transit. Data storage, this gets at the data life cycle that we talked about. Data control, all of this. So again, I'm not going to read through these. These are just a tool we wanted you to have. This second slide, second half of that tool on clinical and professional safeguards. So what's HIPAA and legal compliance? Remember that a BAA alone is not sufficient, right? Informed consent, developer credibility. This is about the developer and or potentially the vendor. What's the evidence base for the particular tool? And very importantly, are there emergency protocols? So again, this is a tool. These are a series of questions. There's no one right or wrong answer. What's really important is if you cannot answer these questions, or if the company won't answer these questions, you should maybe really consider pausing implementation of that particular tool. Okay, and we're going to skip this case. If there's time at the end, we will come back to them. Okay, and I actually am starting this next one, and then Donna's going to pick it up here in just a few minutes. So ethics amid regulatory uncertainty, right? As we've talked about, uncertainty does not eliminate our standards. It actually increases the need for very careful judgment. And so, getting back to how do we live responsibly in a seismic zone, right? We're living in earthquake territory. We don't necessarily retreat. We don't have to run away. We just have to build buildings and foundations and practices that can survive the potential earthquake, right? So there's some things we want to think about, right? Because part of what happens is we're practicing in this period where technology and technology capability is advancing far faster than the regulatory clarity. And that means it's a moving target for us, right? So there's this legal lag, right? Where regulation is following innovation. The law is reactive, not anticipatory. Standards typically are evolving after there's harm or a complaint or litigation. And right now, sometimes we don't even know what the standard is because the complaints have just been lodged and they're still going through either the licensing board or the court process. So we're gradually starting to see what will happen. And it means that as early adopters, we are operating in interpretive gray zones, right? Without clear precedent, without knowing, hey, if I sign an AI note and there's a problem with that and that later causes harm to my patient, am I solely responsible? Is the tool going to be held responsible? Is there any sharing of liability? None of that has been resolved yet, right? We also have the fact that there's no uniform standard. State level variability increases uncertainty, right? Licensing boards, we don't yet know how they're going to interpret AI integration. It could be different. Texas may interpret it different than California, than New Hampshire, than New York. And what if you're now practicing in all of those states? Wow, we thought it was a lot to learn the laws of those states. Now we get to learn how states are going to handle AI. So there's a lot that we need to be aware of. And then, of course, the ethical implications, as we've talked about, that ambiguity doesn't reduce our responsibility. When the rules are clear, compliance is straightforward. But when they're unclear, that's when we have to turn all the more importantly to our judgment, right? And I think to each other, tons of consultation. We'll get to that in just a few minutes. I want to talk to you for a moment. We've talked about regulatory uncertainty, but I also want to go back to this concept of internal opacity. And we've sort of mentioned it briefly here and there, but AI systems are often not fully transparent. Their reasoning processes may not be fully explainable or even easily interrogated, meaning how do I find out about it from the company? Many companies won't want to tell you that. And that lack of transparency causes us some problems, right? Especially if it's a tool that's informing clinical judgment. We've already talked about how responsibility isn't there with this system, right? It stays with the clinician. Influence alone is sufficient for responsibility to attach. So if AI meaningfully shapes that assessment, that documentation, that formulation, or some decision that you make, you have some accountability for that, right? Opacity concentrates responsibility rather than diffusing it, and it often can shift downstream onto you, the clinician. The less transparent the system, the greater the obligation for disciplined reasoning and reflective judgment, and for heightened scrutiny, right? So we've talked about this along the way, but that's where you want to add scrutiny, slow things down, get lots of clarity before you continue. So what does a responsible practice under uncertainty really look like? Well, we want to sort of have, there's maybe 4 large components. First, as we know, absence does not equal permission. So silence from regulators is not an endorsement, but it's also not paralysis, right? It simply means that we have to go back and rely on ethical frameworks and our professional standards rather than waiting for external direction. This hopefully is actually, and we'll talk a little bit about this at the very end, but is where we can start to shape the way this is shaping us. And I think that's where we want to head. The second piece that is professional judgment shapes standards, right? Standards of care evolve through research, board interpretation, and real world practice. So under uncertainty, you're not just applying a standard, you're actually contributing to how responsible integration takes place in the field. And that can actually be kind of exciting. Third, remember that consultation protects, and we're going to talk about consultation specifically here. Ethical uncertainty is an invitation to broaden your perspective. We want to be actively seeking consultation. That strengthens your decision-making, it reinforces professionalism, and it's a safeguard if there's any kind of review, licensing board, or those kinds of things. And fourth, documented reasoning defends you, right? When the environment is less defined, clarity becomes valuable. So these are kind of the four broad things where you can really add in a lot of safety for yourself as you're practicing. Now, when we practice under uncertainty, right, particularly when AI is meaningfully influencing clinical judgment, I believe consultation is no longer optional. It's really required. We have to be consulting. And it's a very strong ethical and risk management safeguard for a couple of reasons. Consultation, of course, reduces awareness gaps. As one of my colleagues often says, it allows us to borrow somebody else's prefrontal cortex, which is always nice so long as we give it back to them at the end. But the idea, right, is it distributes cognitive load. It can help us see things that we didn't otherwise see, whether that's a bias or something we weren't thinking about. And very importantly, right, if we are practicing alone, especially in an AI-influenced practice, vulnerability increases. I really think, if anything, AI is going to make us really work against isolation more because it's so essential. Consultation also then distributes risk, right? No single clinician, none of us, can master the clinical, technical, privacy, and regulatory dimensions of AI use. It is simply too big, period, for all of us. It's huge. So responsible adoption requires distributed expertise. That means we've got to be talking with other people, right? And, who you talk with is going to matter. Consultation, not just with colleagues, but with IT consultants, with risk managers, with attorneys, people who can explain to you what that BAA actually says, people who can explain what the TOS, the terms of service, actually says. And then, of course, documenting, as I said, peer review also can strengthen, so peer consultation there can strengthen defensibility, and those cross-disciplinary consultations. Very, very critical. Donna, I'm going to hand it back to you.
This is really not the place where you're expected to be the expert at all times. You simply can't. There might be a slice of this pie where you can be the expert. I'm a big proponent in us being in the room where these products are being developed and using our expertise in psychology to inform product development. I'm also a big proponent of us using our expertise as it relates to advocacy at the legislative level, but we'll never keep up with all that is happening. Right now, the regulatory landscape around state and federal and even across globally AI laws and regulations is so fast that we cannot keep up. And most of it is actually occurring at the state level, with every state having some form of AI legislation enacted, in process, in development. Most states, multiple forms, but every state has a different approach. And I'll show you a few of those. But why does this matter? Well, of course, we're all in states where we probably care about the legislative activity in our states, but we also practice across jurisdiction. So we need to know what is happening in the states where I practice and where I may cross into another jurisdiction and understand not only licensure laws and clinical scope of practice, but now what are the AI regulations and laws I need to be aware of for use and for liability. So let's look at a few of these elements, and we call it a moving target problem because the minute you get a handle on it, something changes. And something that may exist firmly in one area, jurisdiction is much looser in another or non-existent in another. So there's so much to constantly be on guard for. And I don't say this to scare you. We don't want you to just say, oh, well, I give up. But to recognize you're not expected to be the expert. Use the experts, but also recognize your responsibility to understanding what's happening. So let's just take a look at from a state perspective, because I think that impacts us the most in practice. Right now, if we look at I can share with you the website where this image is from, just AI legislation across states just this year. So this is not to say you don't look at a grayed out state and say, oh, well, Texas and North Carolina don't have AI legislation. Yes, they do. They just don't have a current legislative session with AI legislation happening at this moment. But what you can do with this website is drill down into each state and look at what is current and prevalent and on the books in each state. And there's some similarities across states. There are so many differences. We know that state laws are going to tend to carry some similar themes. So we're going to look at, most states are going to take a look at AI disclosure, consumer transparency, deepfake issues, privacy data government, algorithmic discrimination. But every state will be different. So when we look at these common potential themes, in the deepfake world, there's two areas where we're seeing that come up most. One has to do with politics, particularly political ads that have like a window of prohibiting AI generated political media, but also general consumer ads. That then leans into how child sexual abuse laws are changing, because the use of AI generated imagery the technology does not exclude the depiction from child sexual abuse. So states are saying these laws, that these images that are computer generated or AI generated are virtually indistinguishable from real minors. And so we see now reporting laws change, which impacts us, or there being adaptations to reporting laws. We see that in Alabama, Florida, Missouri, Nebraska, South Dakota, Tennessee, tons of states. Consumer privacy laws that we should have a right to opt out of AI automated processing of significant decisions. State privacy, that's a huge piece of government. Every state in the United States is charged with protecting its citizens, and every state gets to decide the best way to do that, which is why states differ in how they approach things and why the laws are different and why we don't just have federal laws, right? We decided that we would be the United States. So when you cross a state line, you're crossing into a new cluster of people who've decided how its citizens should be treated, and that means their laws will be different. But these consumer privacy opt-out requirements, places like Delaware, Florida, Nebraska, Rhode Island have really clear opting out of solely automated processing decisions if there is a legal or otherwise significant effect, like credit or housing or employment. And they require data protection assessments of these types of AI agencies. High-risk AI governance frameworks are things that will deal with algorithmic discrimination and the prevention of such to protect its state citizens, risk management, impact assessment, having requirements for transparency of vendors. We see Colorado has one of the most comprehensive state laws around governance frameworks. So what we're seeing is differences in what counts as AI, but some really common themes of what is concerning about AI from state to state. Let's look specifically at health and mental health, which is of most interest to us. And I've given you 4 state examples here, so you can see a little bit of the variability in the state focus. We definitely see that there's AI disclosure requirements across states and limitations. But if you take a state like Illinois, it's very clear if there is any type of mental health AI being used, it has to be used by a licensed professional. So it calls and carves out license. However, it also says and excludes clergy, pastoral counselors, and a few other support counseling type professions that are not licensed. So that's a little iffy when we get into Illinois. Nevada, I think, has one of the most stringent set of AI laws in that it prohibits any use or any vendor coming into its state and selling a mental health or behavioral health app to citizens. If it is something that could and should happen in a therapeutic environment, it cannot happen in an app sold to residents of Nevada. Then with those products, that use can only happen with professional providers. So we have prohibitions on individuals purchasing apps in Nevada, and then a requirement of a professional be involved if they are going to be used. So the guardrails are very much about professional involvement, competence, consent, documentation, consultation. And that's true for us ethically, no matter what the law says. So these are minimum laws. That's what laws are anyway. They are what we as a society have agreed to as deal breakers. Aspirationally, ethically, we must be above and beyond what the minimum legal requirements are by being transparent, accountable, competent, knowledgeable, and aware of what the laws are that will guide us state to state. So now what's happening with lawsuits? And this is where we learn so much about all of our professions, but particularly health and mental health care. And sadly, that is through lawsuits. We didn't get a code of ethics until we had some ethical challenges. We didn't get research ethics until we had some research ethical challenges. What we want to avoid as a profession is harm to our patients. So yes, we want to know that we're doing things right, and we don't want to get in trouble. We don't want our license to be at risk. But our biggest concern is the vulnerable public, the patient that we are responsible to and for. So a few high profile lawsuits that touch on the themes that will probably continue throughout the next decade or so as we begin to understand what kind of policies do we need professionally to guide us. First of all, there was that huge lawsuit last year where Anthropic, who is the owner of Claude AI, was sued because it scraped all of its data from publications using a free library source. And that lawsuit settled, so we don't have a case log yet to identify what is owned by the writer and what can be used by a large language model. What we do know is the judge said if Anthropic had purchased all of these books and textbooks, it would probably be a legal and fair use. But because they didn't, it's not. And so now that's in a settlement phase for authors and publishers. Most of us, if not all of us, have heard and seen lawsuits and stories about people engaging in self-harm, death by suicide, and other really terrible things because something that AI told someone to do. And when we look at the AI that is involved, that's usually an unregulated, open source, not trained AI product, but a product called Character AI was very successfully sued last year when it suggested in using sexually suggestive language that a teenager died by suicide. So trying to foster emotional dependency in these products, and then having language that is harmful to the young person, plus the young person having access, those lawsuits hopefully will diminish because we became aware of them very quickly and very early. Class action lawsuits about some of those decisions until every state catches up with Illinois, I was sharing earlier, that has a really solid law about high stakes decision making with AI. We'll still see class action lawsuits. Most famously, California just has one that's currently going. But we've seen United Healthcare, Humana, Cigna all face lawsuits because AI was making decisions to deny healthcare claims, and that those claims were leading to wrongful denials, according to the court cases, early termination of care, and at least in the case of United Healthcare, what was found to be up to a 90% error rate in these claims denials. And then finally, just this last week, we saw a court in the Southern District of New York. A judge there ruled against an attorney in something that I think is groundbreaking for psychotherapists, psychologists, and other clinicians who have patient privilege as part of their license. This judge held that attorney-client privilege and the work product doctrine did not protect an attorney's artificial intelligence generated documents from being disclosed. So there was no attorney-client privilege because the attorney had used AI to develop work-related documents, and that the communications shared with the platform could not be considered confidential. So the decision was it was no longer privilege because confidential information had already been shared with an identifiable party that was not the client. That is scary to me because that then has something to do with what we may see in EHRs. The real key to this particular decision was the AI product being used the data that was input into the product to train its model. Because data then went from inside the product outside into the company's space, remember that whole continuum of data, where it was being reused and repurposed to train the model, caused privilege to be revoked. If we allow our EHR data to train models, then that could be something we would face as well. We're also seeing that courts are subpoenaing algorithmic decision-making logs,
Wanted to jump in
metadata.
for one second on that court case, the Southern District, because it is a very important case, and we will have to see. Yeah, it's huge and may have serious implications. We don't yet know what the implications will be. I think it was the defendant who put the information into the AI, which might make a small difference, but in particular, the finding could be very relevant to states that mimic or mirror where the patient therapist privilege comes out of or is the same as attorney-client privilege. So some states do privilege differently. Those are the ones where this might be most impactful, but it's the kind of thing we're going to have to watch very, very carefully.
Well, and I think because courts are subpoenaing these decision logs, that is where our documentation of what are we asking and what is our answer that we're receiving from vendors, that's essential because that will be part of discovery, and that actually could be part of your defense should something like this happen. We hope not, right? But because this has already gone to court at the attorney level, we need to look at it at the healthcare level as well. Key trends legally, liability remains human. Liability cannot be ascribed to technology. It can only be ascribed to us. We have increased state regulation, but there is no regulation that covers every potential concern. We don't know what the next lawsuits will bring, and it is our job then to stay diligent and do our best. We aren't the only ones, y'all. This is a global enterprise. So outside of the US, you can look at the EU, who already has very stringent internet privacy laws, really looking at private, health-related AI tools, and is calling them high risk, all of them, and providing stricter requirements for those than any other tools. In the US, it's primarily our private sector innovation that we're having to try to put guardrails around and see what's happening, and our patchwork of state laws and our professional guidance that's growing but cannot catch up at this point. UK and Australia, we see more work happening there with national health, and across Asia, the amount of consumer uptake is huge. And so regulation is really varying across Asian countries. So global direction is more oversight, more documentation, and higher expectations for bias management. It won't just be the US.
Yeah, in some ways, the US, I think, is sort of behind some other countries in
Sure.
some, regulation. And I know there's a debate, right? We don't want to be too regulated. I certainly understand that. And though we don't want it to be a free for all either, because there's harm. So it's trying to find that balance. So, all right, so we want to, the last little bit here, we're going to talk a little bit about how do we integrate this in ethical stewardship. And I also, before we dive into that, want to say, if you're feeling overwhelmed, it's still okay. I think we have talked about a lot. There is a lot to think about, but that doesn't mean that we can't use AI. It doesn't mean AI is already being used. It just means we need to think about it carefully. I think we do want to work towards true ethical stewardship, where we are setting the conversation. We are shaping how this gets used in our field. And to Donna's point earlier, we may need to get involved in various levels to help make sure that happens. But I just want to underscore that, it can feel overwhelming, but it doesn't mean that we can't find our way through this, right? We as a profession have navigated through many, many turns. And I think we will continue to do that. I do, just real quickly, I want to note too, when Donna was talking about the state laws, there are a lot of things happening with that. Your state psych associations are following those. Most state associations are following them very closely. So if you're looking for input and details on what's happening in your state or states where you are practicing cross-jurisdictionally, those are some good sources of information for tracking those laws so you can understand what you need to keep up with. So I do want to bring us back to, right? So all of this is a lot of change. It's a lot of excitement and some things to worry about. And at the very backbone, what has not changed is our commitment to our ethics code, right? Beneficence, non-maleficence, integrity, justice. This is what holds us. So when technology is challenging, when there's all these unknowns, this is our compass, right? This is what we come back to. And I think if we can really, I would say this, and then of course a part of our code is that we prioritize patient welfare, right? We don't want to prioritize our own desires or need for efficiency, those kinds of things. What has to be at the basis is patient welfare. And I think there's a lot of ways that use of AI may eventually help in that, right? We just need to make sure that we walk through this in a solid way. Adoption pressure, meaning to adopt AI, is very real. Efficiency gains are very tempting, right? But our primary role isn't as innovator or optimizer. Our primary role is fiduciary, right? To our clients, to the people we serve. Stewardship, or stewarding this, as I'm talking about it, means that we're protecting what's entrusted to us. And that's client welfare, trust, judgment, professional standards. Stewardship sometimes means postponing innovation until the conditions are there that support safety, competence, and defensibility. I also think stewardship means getting out there and impacting the world creating this. I've been talking with some developers of AI who, about some of the privacy issues, and they keep telling me, well, it's the tool company, it's the AI development tool who's really going to have to do that. And I think, great, then we need to be talking to developers to help them develop ways to safeguard privacy. Without us pushing that, they're not financially motivated to do so at all, right? So stewardship is getting involved in the ways that it matters. If and when we postpone or pause things, that's not anti-innovation. That's not staying in the dark ages. That's a disciplined pacing under uncertainty. And I think that's what we want to aim for, that disciplined pacing. So again, whose interests are primarily being served? Well, ideally, we want that to be the client, right? Over system efficiency or clinician convenience. But going back, remember that clinical ethical judgment framework we talked about, you can use that to help guide some of these questions. And maybe you've already been asking yourself these, but what role will AI play in your practice right now? What role is it maybe already playing? Where are you going to draw firm boundaries, including potential non-adoption? Or if you do adopt it, where do you want the boundaries to be? I'll use AI for, thought processing or developing psychoeducational tools or those kinds of things. Those are all low risk, right? Again, like I say, hey, if I talk to ChatGPT and say, I've got a 20-year-old who has this symptom, what might the diagnosis be? Again, notice there, I included no PHI, nothing. So just very general. You can even say, I'm creating a vignette, and in this vignette, what might I think about, right? That's different. And may need very different boundaries than if you're, doing something more intensive, like what we've talked about here, risk assessment or those kinds of things, or if you are actually inputting PHI. Very, very different boundaries need to be drawn. How will you, as the clinician, build and maintain competence in AI? And honestly, this is a moving target too. I think Donna and I both have been studying this stuff a lot for a while now. And oh my gosh, I'm sometimes overwhelmed at how quickly it's changing and how fast the knowledge that I had 2 weeks ago is now not up to date anymore. So we need to be building in ways that we each can continue to build and maintain competence in AI. Certainly trainings like this, but how are we going to maintain that long term? Who are you going to consult with? Right? And here you want to consult with knowledgeable experts. Yes, consult with your colleagues, but remember, not all colleagues are going to be experts or knowledgeable in AI. So you want to really be talking with people who are, right? Risk managers, IT people, and sort of like not all BAAs are created equal. Not all IT people are created equal. As lovely as they are, there's differences, right? And if you're going to consult an IT person, you want to talk to an IT person who understands behavioral healthcare issues and privacy issues and security issues. Not all IT people do. You also want to talk to someone who understands AI specifically. Not all of them do. So very important to be consulting. What practices are you going to engage in to prevent that gradual authority drift? And this, I think, is really important for all of us who use AI. I think we actually need to give real thought to this and have actual practices that we use. It can't just be, well, I hope it won't happen to me. That's a problem, right? That's where the risk is. How will you ensure that your documentation reflects your reasoning rather than simple AI output, right? And how are you going to revisit and update that informed consent? And I do want to mention one thing here on the informed consent, because I know we covered that somewhat quickly. But I've had multiple conversations with practitioners who say, gosh, Liesl, if I really put everything into my informed consent that you want me to, right? Where's the data stored? How's it, all that stuff, then my patients will never, ever agree to use it. And that's sort of given as a, so I don't need to be that transparent, right? Wrong. In my opinion, that's really wrong. If you really think your patients won't use it because you give them an accurate understanding of the tool, I think we've got to let that decision lie with the patient. I don't think it means that we can hide the reality of the tool or the risks. So It may be that then you would need to look for a better tool that has less risk. I don't think curtailing informed consent is the way to protect against that. And remember that you can develop your stance towards AI. You can adopt a lot of it, you can adopt it selectively, or you can still choose not to adopt it at this point. But again, the main thing is you shouldn't choose, or we'd like to advocate you not choosing to ignore it altogether, right? We have to become, we have to gain digital literacy. It's here, it's happening. And in all reality, it's happening even if you don't know it's happening. It's impacting you, it's impacting your patients. That is really occurring. So sustaining ethical competence. I just want to note competence, well, generally, but certainly not with AI, it's not a single skill. It's really a system of multiple domains, right? It's first about self-awareness, our own self-awareness. It's about technology. If we're using those tools without understanding them, we're not really competent, right? Competence also includes knowing when to not use a tool. Now, we don't necessarily have to be a technologist. That's why we have consultants, but we do have to learn enough to learn the language, to know what questions do I need to ask? How do I evaluate whether this is safe in context A, B, and C or not? And I want to also mention, because we haven't before, if you're using AI in any of your clinical workflow, we recommend having a written AI practice policy, right, that you can give to your clients for your own clarity and for defensibility's sake. Back to competence, right? So we've got our competence. We also then, ethical use of AI requires understanding vendor terms, data policies, BAAs, reading the terms of service agreements. There's things that make us sort of want to just like roll our eyes and forget about them. We have to know what they say. And as I've mentioned, consultation, right? Very, very important. We have to engage in consultation. And our fiduciary responsibility really is what anchors this entire model. Client welfare, first and foremost. All technical decisions pass through that filter. So how do we act ethically when so much is unknown? Well, if you're going to adopt AI, start low risk, proceed slowly and thoughtfully, right? Consult a lot. If the risk is too high, just pause on adoption right now. I promise you, 6 months, things are going to be very different. So if you're looking at a tool and you think, gosh, I'd really like to use it, but it's just too risky, wait a few months, things might be very, very different. This is happening very quickly. So don't, pausing is not a bad idea in some instances. Maintain transparency. So again, this is back to that informed consent. You've got to tell your patients the risks and the benefits, not just the benefits, right? And offer meaningful alternatives. Document your own independent rationale that we've talked about. Consult a lot, consult early, consult often, and consult again. Because remember, you may adopt an AI tool today. In 3 months, that AI tool may be working very differently than it did when you adopted it. We need to stay up to date on that. Revisit your decisions about AI regularly. Because again, things are changing, tools are changing, evidence is changing. And importantly, I think now, especially in the next few years, we're going to see regulations start to really evolve. And very important that you develop active processes so that you are aware of changes that are occurring for your state, for any cross-jurisdictional state, in AI development, all of that. We've got to have active ways that we're staying up to date on this. And again, for those of you who are like, I don't want to touch this, non-adoption is a defensible choice. I see, Andrea, I've got 2 more slides and then I'll hand it over to you. So beyond fear and hype, right? That's the whole point today. Yes, caution and concern are warranted, but fear is not a strategy and neither is uncritical acceleration, right? We want to find that sweet spot. AI can assist us and we need to remain in the driver's seat, period, end of story, right? As AI tools evolve, our ethical obligations actually deepen. Okay, so we want our judgment leading everything. And the last thing I just want to leave you with, again, AI is already shaping clinical practice. It's already shaping. What we want to do is shape what's shaping us, right? Every technological inflection point in our field has required us to mature, not to retreat. So that's what we want to do here, right? And we hope that our talk today will help us meet this moment, so that we can ensure that our judgment stays central and we can uphold the fiduciary duty to those we serve. And importantly, we got to do this together, right? So beyond fear, beyond hype, with disciplined discernment and in good company of each other, marching through this shifting world together. And Andrea, over to you.
Thank you both so much for this presentation. It was so full. The breadth was incredible, the amount that you were able to get through. So as expected, there are many more questions than what we'll be able to get to, but I have grouped them together into categories to help our conversation. So the first is looking at authority, judgment, and then ethical drift. The question is, de-skilling is one of the more predictable consequences of AI in clinical practice. And that is most real when we think about clinical decision making. What stands in the way of creating ethical space for clinicians who would like to preserve clinical decision-making as a human-only process, at least in the coming years, as we see how this transformation plays out clinically?
Well, I'm not, I can jump in initially, and then I was doing something on my computer, so I'm not sure I heard the
What
entire.
stands in the way is the key of the question,
Mhm.
right? And I think one of the things that we have continued to hit upon is we don't want anything to stand in the way between your human decision and clinical decision making, because of AI.
Mhm.
AI should only ever serve as a support, but your decision making is always going to be what should triumph over any use of a tool that may automate some base tasks.
Right.
But please go ahead, Lisa.
Yeah, I think if I heard it, part of the question was about de-skilling, right? And this is the idea that if we rely on AI again and again, we lose our ability to make those judgments ourselves. We lose our clinical edge in a way. That's the fear. So I love this question, whoever's posing it, because I think we do want to create spaces where we as clinicians continue to practice those skills. We do not want to turn that over to AI. Because then I think we lose the human component, right? And so I actually think we need, as AI becomes more a part of our work, we need to actively create places where we are continuing to use our own judgment. That may be, in consultation, it may be who knows what. But I also think it's important to think about how are we training our students so that they're, not just relying on AI and they're developing these skills as we go. So I think it's one of that de-skilling is something we need to work actively and thoughtfully to ensure doesn't happen.
And I think that's something that comes up all the time and actually addresses another question that was in the list, which had to do with why would I use AI for some more routine tasks than given all of this? So we don't want to de-skill on something in clinical judgment like a treatment progress note. However, we know that providers are struggling to get documentation in a timely way. And when we delay documentation, we move further and further away from the truth. So we teach young clinicians how to do the work, know what goes in each note or treatment plan. I prefer to stick with notes because that's where I see it really as a more supportive product. But we're seeing documentation rates improve by 70% using some AI assistance. That's good for the agency, that's good for the clinician, that's good for provider burnout. That's good for a lot of situations and good for the client being served. But it cannot happen unless that clinician knows what goes in that document without AI support. It
Yeah,
can't
so
happen that way.
here's a related question. So it's how do we balance innovation and clinician excitement about that innovation with restraint when the standards of care are evolving?
Yeah.
Yeah, well, I think there's no one right answer to that. I mean, I think part of the answer is doing what we're doing today, which is a lot of continuing ed. It's consulting. It is, yes, finding out, I think playing with and practicing with AI outside of high risk clinical areas. So we're learning, how does it work? How does it function? Where are the risks? I mean, even when if I'm just using ChatGPT or Claude, I can ask it an example and it'll give me an absolutely wrong question, right? If I say, tell me the law for Texas on X, Y, and Z, I can't tell you the number of times it's given me an absolutely false law that doesn't even exist, right? So, and that's outside of the clinical world. So we can do some of that, but I think a lot of this is we're going to have to talk to each other so that we're sort of, it's a fine middle line of not letting our excitement run away with us, nor letting our fear run away.
Right.
And I think we do that best when we do that together. So that if I get too far in the excited place, one of my colleagues can say, Liesl, slow down. But also if I get too far in the fear, my colleague can say, hey, we don't have to be that scared. Let's find another way. I think that's really important. And honestly, it's this moving target. It's not going to happen all at once. We're going to have to navigate it for a while now, I think.
We've never navigated anything this quickly. The internet was not this quickly phased into our lives. EHRs were not this quickly phased into our lives. The automobile is not this quickly phased in. This is the most rapid escalation of any form of technology we've ever seen. So it's okay to take a breath and say, wait a minute, I'm not sure about this.
There are also questions related to confidentiality and even breaches in confidentiality when we're not thinking that there would be. And so this question was, there was a recent data leak of the Chat and Ask AI app that leaked all the conversations of 25 million people that had been using that app. There will be more data leaks like this in the future. Shouldn't we be worried about confidentiality and HIPAA and act conservatively anytime we translate therapy to text and data? And then as a secondary part of that, also, won't our use of AI then serve as a training data for improving AI therapy apps?
So to that first question, yes, and yes again.
That's what I was thinking too. Yes to all of those. Yes, you're right.
I mean, honestly, for me, confidentiality and privacy is one of the things I worry about the most.
Yeah.
I know that, yes, we all are burned out. We all need help with notes. We all, and yet, oh my goodness, patient verbatim sessions are going into data systems that some clinicians have no idea where they are.
Right.
There is big money in big data. So these companies are amassing huge data. The BAAs usually allow them to sell them to third-party vendors. So this is where, I mean, honestly, it does start to, I get very stressed because I do worry about this privacy component the most. It doesn't mean that it's not surmountable. Like we can find a way through, but what worries me now is I see a lot of clinicians just accepting this concept of, oh, it's HIPAA compliant, therefore it's fine. That is not enough. And I worry very seriously, we are going to see many more breaches to come and some real harm.
We will. Think about just the sheer number of times you get notified by a vendor that may be financially related, your insurance, your mortgage, your bank, your account with DoorDash, that there's been a data privacy breach. The same encryption is happening in banking services as is happening in these types of clinical adjacent apps. At best, it's that level. So there will be breaches. We have to be radically protective of what goes into the products that we choose to use. There's a great additional question in the group about how you vet a BAA. Like, what do you look for? That's one of the things you look for. So I can say, oh, this is HIPAA compliant. We have a BAA, but the BAA says we can sell your data to a third-party vendor and all of your data is used to optimize our training. Well, that's HIPAA compliant, but it is not my compliant. It's not good enough for me. So every BAA is going to be different, and knowing those questions to ask will be that we did not get to, but that's an important, I think, call out too.
And so
And I
I'll encourage
where
everyone listening to make sure that we're paying attention to the resources because there are some resources that you all include on additional things to think through, and that's certainly one of them too. I'm sorry, Lisa, I think that I interrupted you when you're getting ready to speak.
Yeah, no worries. No worries. I was just gonna say, I think because in the mental health field, right, it's one thing if a bank, someone can access my account, that's gonna be miserable, of course. I don't want that. But that's different than somebody learning about what someone's trauma history or someone's substance abuse or, very sensitive information that could, if your employer finds out about it, you might lose your job. Or I mean, it can have very serious implications. So I think our ethical responsibility is actually greater than in some of the other fields because
Exactly.
the information we have is so sensitive.
It's life and death. Banking feels life and death. It's not. This is life and death. There are several people who are asking, so is there a company I can trust? Is there a tool that I can trust? And Lisa and I talked about this at length. The minute we say this is a company or a tool that seems to be doing it right, either something will change, they will go out of business, or the regulation landscape will change and they no longer meet what we've now decided and should be minimum. So getting into tool recommendation is so far outside of what is reasonable at this point, because every tool requires an independent investigation by you, the clinician.
Well,
Right.
and just to add to that, sorry, Andrea, just one quick thing, and then I know you want to get to another question. To add to that, right? It's not about is the tool safe? Remember, I said clearly earlier, that's the wrong question. The question is, should you be using the tool in your context,
Yep.
in the role you're going to do it with judgment issues, right? So we can't possibly say tool A is safe because we don't know how you're using it, right? That I think gives way too much authority to the tool as if it's something inherent in the tool that makes it safe or not safe. And it's much, much more complex than that.
And I really want to underscore that because in this presentation and others too, when we're talking about AI, there's a frequent question of, well, just give me a checklist, give me a list of tools that I can use.
Sure.
And we would love to do that. But for the reasons that you all named, it just wouldn't be prudent to do it. Instead, what we will give you and what you all did today too, is to give a checklist of things you should be considering before using a tool. And so I just want to underscore that. It's hard for us to determine what tool would be useful for us that adheres to HIPAA and all the other privacy constraints that we have. But one person asked a question about how do we make AI disclosure understandable without overwhelming our clients if we
Yeah.
are overwhelmed at the same time?
Right. Oh, that is such a great question. And one of the things that I teach in my clinic, because we do have an AI requirement in my training clinic. It is an e-clinic for a reason, separate from our telehealth clinic in our general clinic. And in the onboarding, we teach our students what all of the parts of the tools that we use, what the answers are to the questions that we have asked, and how to talk to your clients about what we use, how we use it, and how they are protected, and answer their questions. That language is challenging. And I think about it like any other ethical informed consent, which is it's not about giving the information. That's only one part. It's about sharing the information in a language that can be understood. So already we're at a deficit because we don't understand all of the tech language. We have to start there. We have to understand that language if we're going to be able to give that language to our patients in a way they can understand it. I know that the trust is working on developing informed consent documentation language and resources and tools that can be used by providers. Because if we look at our informed consents by and large, we carry a lot of the same language across consents, even in different practices by different providers. We'll see some of the same phrases and some of the same elements. And we are just getting there with AI. Up till now, it's been the Wild West about what to tell our patients if we use AI. We have not had a standard. So I'm glad that the trust is taking on some of that to provide some guidance there. Lisa, I know this is an area of concern for you.
Yeah, I just want to add, I mean, I agree. I think it's a really important question. So a couple of things. One, if we ourselves as a provider are feeling really overwhelmed and not sure, then I would say slow the process down, because that maybe likely means that we as the provider don't yet know enough, right? If our anxiety is super high and we maybe don't know the language, we're not going to be able to share what we need to. So I think one of the big pieces is we have to become competent. Now, that doesn't mean we have to become IT, AI gurus, but it does mean we have to become competent in the language, in the same way that if I'm going to do EMDR and I've never done it before, I have to go out and get trained in EMDR so I understand the language, so I can explain it clearly and in plain language to my client. So I think we have to understand AI to that degree.
Mhm.
And the added piece, I think, is that no one knows all of the answers right now. This is an evolving evolution, really. AI is an evolution. It's not even a tool per se, right? It is evolving. And I think part of our informed consent has to say, here's what we know about the benefits, here's what we know about the risks, and very importantly, here is what no one possibly knows right now. And you as the patient have to understand there's some things we can't know. There may be risks that may come back to bite you or me. That we can't foresee. And so some of it is for all of us being comfortable with in some ambiguity. And I think as practitioners, erring on the side of protecting patients and patient data above all else.
And cautioning what we can promise, because what we can promise when it comes to the technology is limited. We do not control that technology. We can promise what we have signed. We can promise our understanding. We can promise what we have learned about the tool and why we're using it. And we can promise to follow up if there's ever any output that appears to be misrepresented or not in alignment, or when the patient has questions. One of the biggest parts that I think we forget about when we finally do learn a tool and we get excited about it is we have to constantly monitor the outputs of that. We cannot just then say, okay, this is good. Everything will be fine that comes out from here on out, because that's not true.